Hello, John Stephen. Hello, John.
Yeah, hello.
How are you?
I'm fine, I'm fine.
I'm John Bennett, the administrator.
Yeah,
Where are you from, John?
I'm from Tanzania.
Oh, excellent. Welcome.
Thank you very much.
Have I met you before? Because we had a conference in Tanzania.
Yeah, we have, I think it was last year.
Yeah.
Yeah, by then I was amongst the ones who were presenting that conference.
Oh, okay.
Yeah, but I was not an attending yet. At that time, I was finishing my training.
Oh, okay. So you finished your training?
Yeah, I have done.
Oh, great. Great.
Yeah, yeah.
At the same hospital now?
Yes. You mean at this time?
Yeah, you were at the same hospital as before?
No, another hospital, but the same department, neurosurgery department. We collaborate with the previous hospital.
Oh, okay. Welcome. Okay, welcome. Amir, how you doing? This is a Ukrainian neurosurgeon. Hey, how you doing?
How are you? Fine,
Boy,
thank you.
it's going great.
It's great to see you again, Mr. George.
Well, now we're going to start with China. China is interested in they want to start a channel.
Neurosurgical channel.
Yeah.
Chinese neurosurgical TV.
Yeah. Why not? you know who wants to do it is Bin Hu, the expert on Moyamoya, the neurosurgeon from Shanghai, Bin Hu. Let me show you. Let me show you. I think you've seen him before. Oh, I can't find this picture. Okay, well, anyways, we'll be. So how's it going with you? You do Facebook Live? You do more video or no? Oh, he's not. Amir, are you doing more video? Are you doing Facebook Live or no?
Yesterday,
Oh, good.
I did. No, it's yours.
Huh?
It's your webinar. I had.
Oh, yeah, you're watching. I was experimenting. Okay, I'll be back, okay?
Okay.
Thank you, man.
Okay. There's Abraham.
Dr. John, how are you?
I'm on the beach again. How you doing?
Good, good. Thank you.
It's going wild, I'll tell you. We're getting serious numbers of people here.
Yeah.
So, and I just heard from China, they want to start something.
Well, you're doing this 24/7, aren't you?
No. You know, it's like medicine. You know, you take naps and you get, you know what I mean? But you know, when you got the passion, you know, it's not about sleep, you know.
Right.
Yeah, you know, it's like I don't know, it's the same with neurosurgery, but most of the neurosurgeons I met, they run on passion.
Right.
You know, that is, you know, how else can you explain it? Staying up so long, you know, days at a time. So, you know, you can't explain it. It's hard to explain to people, you know, people that aren't in medicine. They wouldn't understand.
Right. But it's amazing what neurosurgical TV has become. It was an incredible development.
Yeah. What do you mean? The development of the science itself?
No, I mean neurosurgical TV itself as a platform.
Oh, yeah,
I
yeah.
remember like the first webinars I joined were in 2018, I think.
Right. Oh, we did them before then. We did them.
Yeah, I know, like 2016 or something.
Yeah, a long time. Yeah. You know, it just wasn't catching on back then. It just wasn't, you know, there was a solid small minority that, like you maybe, that believed in it, but most people were kind of skeptical to try. And I think a big reason why, which I'm seeing now because of Corona, is that people didn't even want to look at it, but now they kind of have to look at it.
Yeah, absolutely.
And they're saying that, hey, this is, you know, I don't have to explain what it is. I just say Zoom. People know.
Yeah.
And that name, Zoom, it's incredible how that's embedded into the consciousness of society now, which for a company, that's golden.
Right.
To have people think about their company name, you know, like, you know, Skippy Peanut Butter, that's before your time, but it's you know, it's way back.
Yes.
I don't know if it's a brand name now, but back when I was younger as a kid, Skippy Peanut Butter, everybody knew what that was, the brand. And it's the same thing with Zoom.
Hello.
Hello, how you doing?
Yeah, I'm fine, John. So when are we gonna start?
Oh, okay. Who am I speaking to?
This is Dr. Mallappa from India.
Oh, okay. Are you starting? You're not presenting, correct?
I think it's around 5 p.m. Another 2 minutes maybe.
Okay. I think Mustafa is presenting, correct?
Yeah. Yes.
Yeah.
Dr. Mustafa.
Yeah. He's
And
starting.
many congratulations to you. I really applaud your efforts. Here in India also it is slowly picking up. Neurosurgical TV is slowly gaining its foot even in India also. I think many
Good.
people are
Very good. Very good. We hope to see it develop wider and deeper. And I think once you stick around, you'll understand this technology, why I think it's so great. I think it can improve education, improve it, and improve interaction. And
Sorry if I interrupted you.
go ahead, no problem.
Yeah. Thank you.
Okay. We'll be starting in once the speaker gets here. That would be nice. Oh, Abraham, you want to give the talk today? Okay, Dr. Shah.
John, I had a small doubt.
Yes.
What would be better, whether we see it on the neurosurgical TV app or this Zoom is also equally good? I mean,
No, you see it on the website, Neurosurgical TV, and it'll
Yeah,
be
yeah.
archived. It'll be put in a YouTube channel of
Sure.
Neurosurgical TV, and I'll put that link down now in the chat room.
Sure.
'Cause that's-
I think I already have the app, but now I logged in through the Zoom, so I just.
Okay, okay,
Okay.
yeah, they're all,
Anyway, just put that in also in chat so that others could help others.
yeah, it's that's, let me get that.
Thank you.
Yep, that's one of the links I keep handy. Okay. Do you see that in the chat?
I'm just checking it out. Just give me a minute.
Okay.
Hello, John. Can we directly download the app through the Google? Directly download the app and log in.
Can you download the app on what?
Yeah.
Yeah, you should be able to go to the Google Store or
Google Store,
Apple
yeah.
Store and download the app
Yeah.
that way. Yeah.
Yeah. Sure. Thank you.
Okay. Oh, okay, Ipe's here. Ipe will save the day.
Hey, John.
Hey, Ipe, how you doing?
Pretty good, John.
I was getting nervous. I thought I'd have to do it. Hey, I heard from China. They want to start a channel. Ben who? You know, Moyamoya.
Yeah, Binzu.
Yeah.
He's a good friend. See, John, the young neurosurgeons of Africa, Azim just called me and he wants to start a channel too. So we're looking at a lot of channels with neurosurgery coach and neurosurgery TV. So again, Luis was talking to me the other day. So he is having a SBN with the Brazilian Society. So Ali Krish, Prevedello, all these guys are there. So I'll try to get them in through the neurosurgery coach and neurosurgery TV.
Okay.
So thing is, I've been lazing it out. So every day we're operating a case and then I've been lazing it out a bit. So, but yes, let me get all these collaborations together and we'll have a lot of guys to talk in the next 1 month or so. So I'm sure it's going to help these boys a lot.
Well, being consistent every day is good.
And
every day. That's good.
Yeah, we're going to show tumors, spine. We're going to show every type of varied things. So this is what the plan is. And I was thinking maybe we should have a panel where all these guys bring on all the questions about strategies, operative things, and things like that. So there's a discussion on these kind of, I mean, if you can collect about 25 questions that they send, I mean, we let there be 100 questions. We select a group of 25 questions and we answer them.
Oh, that would be good. Hey, hi, Mustafa. Excuse me. Hi, Mustafa. Hi, I gotta unmute you there. Okay, go ahead.
Hi.
Mustafa.
Hi.
Hey, Mustafa. Good to see you, man.
Hi, IP.
I'm John
Hi,
Bennett.
everybody.
John Bennett.
Mustafa, good to be. I'm having you here. So we're looking forward to your talk, and not one, many talks, man.
Thank you very much. Thank you. I'll do as many as I can, and I appreciate the opportunity. It's a lovely group, very active. Thank you for your leadership.
Not at all.
Do you
My
have
pleasure.
any, excuse me, Mustafa, I'm John Bennett. Do you have any videos you're going to play on your presentation?
I have so many of them. Yes.
Okay, because are you going to use the sound at all on the videos or?
I try not to, so it doesn't interfere with my.
It's okay, you can do it. I just have to set it up correctly on my end of it.
Good.
You can do what you want, but I have to set it up correctly. Here, let me, okay. Okay, it should be okay now. Okay, okay. Oh, what is that? Is that me? Oh, sure. Oh, it's me. Okay, let me just let some people in.
Should I start?
No, let me get
Not
some.
yet.
Hold on, let me get some people in here. More people. This is, now we're getting a lot of people come at the last minute, you know.
Of course, of course. We are neurosurgeons.
I'm gonna get that.
We just started. Maybe a couple of hours, and then I'll be free.
Okay. Okay, you ready to start?
Okay.
Okay, hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett for neurosurgery. I'm sorry. For professional production here. We have another episode of Neurosurgical TV, and I'll just turn it over to Ike, and he can run it from here. Good morning, Ike.
Hi. Good evening from Nepal, and we now have Mustafa with us. Mustafa is from United States, and he is a very well-known educator. So I'm proud to have him here and present his first one of the series of talks that he will be doing. So let's sit back and enjoy. Over to you, Mustafa.
Okay. Let me share my screen. I don't know what happened, but it's not shared.
Yeah, you're getting onto the Zoom. Go directly to your PowerPoint and don't even go to the Zoom at all. Yeah, you better get off that Zoom.
Can you guys see it?
Yeah, now it's good. Now it's good. You have to maximize it. Yeah, perfect. Perfect.
Okay. So good evening, good afternoon, good morning to all over the world. I thank you very much for having me. Dr. Bennett, thank you for helping us. And I'd like to thank Hira too. She's been very nice and instrumental helping me. I am computer illiterate guy. Today I would like to talk about the role of microanastomosis. Where are we standing, and where are we going? Where are we heading? First, I have no disclosures, and I like to also thank and salute all frontline medical professionals and first responders fighting against the COVID-19. Where is at least this is in the United States, may not be true for all over the world, but is microsurgery for complex vascular lesions is really fading away. And who should do this? Should we neurosurgeons or hybrid neurosurgeons, open neurovascular surgeons? Are we training neurosurgeons to be microsurgically proficient? And while we are doing all these, should we be minimalist, or should we be maximally safe and as much as less invasive when we are performing this? Who's going to deal with this intraoperative rupture when it occurs, or who's going to deal with this M1 rupture during the angioplasty? We need to answer these, and I think I'm sure all the audience here, their heart beat for the microsurgery. We are microsurgeons. We are neurosurgeons. We are not radiation oncologists. We are not radiosurgeons. We are surgeons, and microsurgery is the way to go. Doesn't matter how you perform, how you do, but principles set by the pioneers like Yaşargil, if we follow that, it should be okay. So after this introduction and getting excited about microsurgery, why do we do the bypass, right? Well, we do bypass for occlusive diseases. If we need the flow augmentation, like atherosclerotic occlusions or Moyamoya type occlusions, or if we need to do flow replacement, complex aneurysms, giant fusiform aneurysms, traumatic aneurysms, or complex skull-based tumors, or sometimes we cause the injuries, vascular injuries, and those are iatrogenic injuries, and we need to repair them. And sometimes we do for the prophylactic purposes. If we have a giant aneurysm and we expect long temporary occlusion time, you do prophylactic protective bypass. So what type of bypasses commonly we use? Most common one, we know that, the external carotid artery to M2, external carotid artery to ICA, occipital artery, M2, and then we have in situ bypasses. A3 to A3 is the most commonly used, and then followed by pica bypass, and some interposition graft options. Which is the most common donor artery is the superficial temporal artery, occipital artery. We have alternative donor arteries like internal maxillary artery, posterior auricular artery, and the interposition grafts most commonly use radial artery and the saphenous vein. And there are some also alternative grafts like tibial artery, cephalic vein, and descending branch of the circumflex femoral artery, which we use first time. And this is how I do. When I do a STA MCA bypass, it's kind of busy, hectic slide, but always keep the grafts warm and keep it warm and moist with the niprite, sodium nitroprusside soaked gel forms. And when you perform the adventisectomy, it should be perfect. It shouldn't be near perfect adventisectomy. That's the most important part of the bypass surgery. And avoid always pinching or squeezing the vessels that cause thrombosis, and gentle manipulation, not pinching, and always avoid back wall stitching. That's another reason. And long arteriotomies and fish mouthing. That will increase the anastomosis area. And we use a Wisconsin broth. We call it Wisconsin solution. I learned this from the cardiovascular guys, and they learned from the transplant surgeons, pioneered the liver transplant here. So, but we don't have perfect conditions all the time. Sometimes we don't have a good donor. We have very atherosclerotic calcified vessels, and this is more and more common in aging population we are facing. And sometimes the donor artery you may want to use might be is a collateral flow. So you cannot just take that artery or STA or occipital artery. And sometimes in this aging population, we have other diseases that will prevent us to use saphenous vein, for example, venous insufficiencies, some rheumatological diseases, and sometimes for congenital reasons or iatrogenic reasons, these vessels have been used before, you cannot use again. And then sometimes the lack of palmar arch, collateral circulation in the arm, you cannot just harvest the radial artery. So then what we're going to do? That's what I'm going to show you. This is not just lecture that I'm going to tell you I have done like 100 bypasses, I have best results. I'm going to show you some complex cases that I ran into trouble and how I got out of it, how I got bail out of it, and what I learned from the other disciplines. So I'll start with the simple ones, Moyamoya disease. So why do we do bypass in Moyamoya? Moyamoya is a progressive disease, and our Asian colleagues see more than us here in this part of the world. And revascularization is indicated for symptomatic pediatric and adult Moyamoya patients. Yes, you have to do lifestyle modifications. If patient is smoking, you have to stop smoking. We invariably put this patient on aspirin, but we do just to do it. There is no benefit from the aspirin. There is a benefit from the aspirin if you do bypass. Angiographic progression with reduced perfusion, even in avascular asymptomatic patients, I wouldn't blink my eyes to do bypass. And there is no real correlation between angiographic progression and the clinical progression. So how do we do the revascularization procedure in Moyamoya? Direct revascularization. This is immediate help, and you don't wait 2-3 months to develop the collaterals from the indirect bypass. And in adult hemorrhagic Moyamoya is very likely it's going to reduce the risk of hemorrhage. Indirect revascularization, there are so many ways of doing this, and I use also, and then combine direct and indirect revascularization. I'll prefer doing this one because one gives me direct effect, the other one is the chronic effect, and it supplements each other. And I don't deal with the pediatric Moyamoya patients. They are done by our pediatric colleagues unless they want to do direct bypass. How I do it, I learned this when I was a Sugita fellow in Nagoya. I'll do frontal branch here, direct bypass, parietal branch. I will skeletonize and suture to the pia after opening the pia in multiple places and then suturing it to the dura. Then I will do frontal burr hole and prepare a small pedicle pericranium and open the dura, roughen the pia, and stuck it there. So and it usually works. I have only one patient failed all over 15 years who continue to smoke. Other than that, I have no failures because I am doing combination of 2 different procedures. And this is an example of it. Young Japanese female and who recently immigrated to the United States. So he had a bypass ischemic symptoms when she was child, and they performed the STA-MCA. It worked well and very nice collaterals. See, but after so many years, for her asymptomatic side, they didn't do anything, and she moved to United States and she presented with this basal ganglia hemorrhage. So now you see she has no flow here at all, but good STAs. So short video summarizing it, preparation of the STA, good adventectomy, ICG green showing the nice flow, and then opening the pia, suturing the parietal branch to the pia and the dura. So then you do the frontal burr hole. This is a very straightforward bypass and nothing important to show, but the show to technique I use for Moyamoya. And good results. She's been actually more than 5 years now. She's 7 years without any ischemic or hemorrhagic episodes and good collateralization from the combined procedure. And what about cerebral ischemia? How I do in cerebral ischemia? this is the toughest part. You know, we have the cost study, we have the earlier bypass study, all failed to show the benefit of the surgical revascularization. I believe some of the data, but I don't believe the entire data. There are certain patients, especially the ones like fits to do this, you know, they do everything. They do this drug, this anticoagulation, this antiplatelet treatment. They stop the blood pressure medications, they raise the blood pressure, but patients still get the perfusion deficits, and patients continue to be symptomatic. I don't need any blood flow study. If patient is clinically symptomatic, if patient cannot get up and walk, that patient needs bypass. This is a perfusion problem, pressure problem, and you need to provide augmentation bypass. So for ischemia, I try to do always double barrel bypass with the both STA branches if they are available. If one available, other one is not good size, then I do combine like Moyamoya. So what if we don't have a good STAs available? I can do radial artery interposition graft, but I always avoid doing high flow, so-called high flow bypasses from common or external carotid artery. I'll find some low flow donor if there's no STA with interposition graft like superior thyroid artery, facial artery, or contralateral STA to do Bonnet bypass. And this is the example of that ischemia case, 75-year-old woman with recurrent strokes, TIAs, multiple trials of the different various antiplatelet treatments, blood pressure modifications, quit smoking. She still gets symptomatic when she walks. She works in the grocery store, 75-year-old. So you cannot just put this patient in the bed and then say, okay, you're gonna be okay because bypass studies fail. So this is how we do. I like to map the STA, both branches, before I make the incision. Both branches. And then we make an incision, almost like a frontotemporal incision, this type. And I'll start doing everything under the microscope. It's much better, much cleaner, and I don't injure. Advantage of the STA, and I can see clearly. You can do sharp, whatever techniques. I know Roku uses the bipolar technique. I like to do sharp and blunt dissection technique, which I learned from the plastic surgeons. And these blunt scissors are very helpful doing the dissections around the artery. You'll see here, artery was good caliber, suddenly is losing its, because it gets vasospasm. This is a teaching point too. Anytime you come close to the arteries, they can get mechanical spasm, and you just don't do anything. Put to nitrite soak or papaverine soak gel foams and wait. See, it came back right away. Finding the trunk and then proceeding, dissecting parietal branch first, and this stretches the and though this is not three-dimensional video, but I'm not using this very low intensity Bowie electrocautery with the Colorado tip close to the artery. And don't do this if you are just beginning to do these procedures, okay? These after developing these skills and sensations, tactile sensations for a long time. Do the safest dissection first. And the bypass for beginners, you should start with the Moyamoya. You cannot fail it, okay? If bypass fails, you can do indirect bypass. Don't start doing the bypass if you are going to do first time in the ischemia cases or complex aneurysm cases. So we do that, we mobilize, and now the adventectomy. Clean adventectomy. This end, I am pinching because I'm not going to use this. Okay? You measure the length and you're going to cut it here. You can pinch, do anything here, but don't pinch it once you make the definitive cut and the fish mounting. And adventectomy is the most important part of the bypass surgery. Again, I'm holding that part, and always mark the site. So sometimes these turn around and kink, and you don't know which side is the correct side, okay? Then you make the oblique cut away from where you manipulate the artery, and always let it bleed periodically, so there's no thrombus formation, and periodically also irrigate with the heparin irrigation, heparinized saline, and clean more. So I'm not happy, and then I'm gonna put the one more time marking, oblique cut, and then fish mounting. And fish mounting increases the anastomotic surface of the bypass, especially in the STA, and then estimate where you're gonna put, and very, very thorough arachnoid dissection around the vessels, and keep them moist and keep irrigation with the warm nitrite solution. See, this patient is very reactive because she was smoker. She quit smoking, but see how it gets vasospasm? Still, you can do it. And always put toe suture first, so it buys the time, and the toe suture is the most difficult suture. Okay? And long arteriotomy with the ophthalmic knife. And then put the heel suture. I like to do interrupted sutures, unless I have a side-to-side bypass. See, you have to create this cobra head, and that is increased anastomotic surface. Only if you make only oblique cut in STA MCA, you don't have a large enough anastomotic site. Okay, so cobra head, and then complete the rest of it, and through everted. It should be like this. It shouldn't be inverted like that. That causes adventitia going inside this lumen, and it will cause thrombosis. So I'm not going to take your much time. You can watch these videos. So then we do one, we take it, Doppler first, take the temporal clips. I cannot find the best temporal clip for bypass surgery. I use AVM clips, I use that clip, this clip, for some reason. I cannot find it. So there's still, I struggle with the temporal clips during the bypass. So bypass is filling, do the second bypass, smaller branch, and do the same thing. And dyeing with the marker pen helps you to visualize, because after you take the blood out from these vessels, they become very transparent. And do the same thing, heel suture first, do it. I don't want to run over the time because I'm notorious for exceeding my times in these talks. I get excited and keep talking. I just warn me if I'm going too much.
Mustafa,
No, we're not strict. We're not strict.
Mustafa,
Yes.
you can talk the entire day, man. You can talk the entire day.
Go ahead.
No
Go ahead.
problem.
Yeah, that's
Okay, John. Thank
Till
you.
you collapse.
okay. Okay.
So then I'll put little Surgicel. You see the bypass, frontal branch, parietal branch, double barrel. Okay, this is what I achieved. And she looks good, immediate post-op, and she remains without any TIAs or any ischemic episodes for more than a year. And she quit smoking. That's the most important part. Atherosclerotic or moyamoya, if they're smoking, they're going to have problem in long term. Your bypass will go away. Your indirect bypass will go away. Or if they have uncontrolled diabetes, you have to control diabetes. So now these are the simple, straightforward, I'm not going to call simple, but straightforward cases for experienced microvascular surgeons. What about when we encounter these kind of cases now? So look at this case. This is 48-year-old man. He's homeless. He has a history of protein C deficiency. He's prone to be hypercoagulable. He had a right carotid endarterectomy and stroke in the past. And he had wrist stenosis of his carotid endarterectomy site. He doesn't follow up. And he gets a stroke, comes to the stroke service. Now his entire common carotid, ICA, and the external carotid, everything is completely occluded. And they try multiple antiplatelets, anticoagulation regimens, and he's mildly hemiparetic. And anytime he gets better, he goes to the street, he gets stroke or TIA, comes back to the hospital, and they try something else. And finally, they asked me to evaluate him for surgical option, but not the bypass. This is very interesting. They thought this patient is having a stump pressure from the occluded common carotid. But if you study this well, his common carotid is completely gone. And the perfusion studies shows perfusion deficit in the watershed areas. This is not an embolic phenomenon. This is a flow phenomenon. And if you talk to him in detail, he goes to the street, he gets dehydrated, he gets symptoms. So it's a pressure issue. So, okay, now we establish we're gonna do bypass, but how are we gonna do bypass? Because there is no conduit here I can come up with. There is no superior thyroid, there is no common carotid, there is nothing. So what options I have? We know that we need to do revascularization, but what kind of conduit should we do from the other side? He has a very nice left STA, superficial temporal artery, so-called Bonnet bypass, or should I do V3 to do V3 to do MCA bypass? And when you do Bonnet, especially if you are doing first time, so I decided to go ahead with the Bonnet bypass, okay? And you know, Spetzler did this very first time in early 80s. And it's very difficult to estimate. First of all, radial artery, you cannot use radial artery. It's not going to be long enough. So you are dependent on the long conduit like saphenous vein. And if you do, like we always do, distal bypass first, two problems. One, it's hard to estimate the exact length, and you need to feel retrogradely, and it takes too much blood. It's going to steal blood from the cerebral circulation. So for that reason, you have to do the proximal bypass first, contrary to the other bypasses we do. So, and then when you do that though, you have air embolism issue. You have to get the air before you take the temporary clip. And you have to create a groove in the both frontal bones, so bypass can sit safely, scalp doesn't compress and occlude to bypass. So I'm going to show you this case video. This is the first bypass, Bonnet bypass I did. And it's showing all the imaging again. There's a significant perfusion deficit. We're going to show you the perfusion studies later. So in the watershed areas. So patient needs this actually published. So I took this video from the publication. That's why you are seeing this, some imaging you already saw. No good collateralization from the other side. This is left common injection, nice. And you see the stroke area and the watershed area decrease cerebral blood flow. and perfect indication for it. And these are the alternatives to Bonnet bypass. The reason I didn't do subclavian is very long, and I have to involve vascular guys and other things. It's very unnecessary. V3 to MCA bypass, I didn't do because he's not very reliable person. So I don't want him to go to street and then do something and they pop the bypass. So this, you have to do bicoronal incision for Bonnet bypass. Again, you have to expose the contralateral STA. In this case, left STA. It's very nice, robust left STA. Then you go to the ipsilateral side and you have to do your craniotomy, which is a bicoronal incision. But craniotomy is not bifrontal. It's craniotomy just ipsilateral frontotemporal terminal craniotomy. Elevate the bone flap. And now vascular guys are harvesting the saphenous vein from the leg endoscopically. Perfect conduit for Bonnet bypass. Like I said before, radial artery is too short. Longest radial artery you can get 21 centimeters. That won't be enough. And you go to the now the sylvian fissure. You have to have a very wide dissection, and that's why I took this vein. Normally I wouldn't take any vein, but this was necessary to take and go around it. See, you see this flow. So you see very white, pale artery. It Dopplers very slow, and there is a good ICG green flow, but it's very slow. So it's still live, but it's not getting enough pressure. So that's why bypass is indicated. And this is the ipsilateral STA, I'm sorry, contralateral STA, long arteriotomy. For this saphenous vein grafts, you don't have to do fish mouthing because there's a large enough area. So, and use 8-0 sutures is very good practice for chief residents and fellows because there is no concerns for temporal occlusion, ischemia time. This is completely extracranial and is 8-0 suture. So you can have, if you have a good fellow or good resident, and they can do this part of the procedure, or at least they can do one side to train themselves. So no time concerns. And again, I think after one point I had my chief resident do some parts of this procedure, and you complete that. You take, see, immediately backfills the graft. So you need, now you can estimate the true length you need. So then that helps us to create a groove in the bone, and it has to be wide enough. And you have to anchor this graft to the muscle and the bone so it doesn't move and then kink. And this type of rare bypasses is not technical, it's mental. You have to, in your mind, before surgery, like we study the cases always, but in this case, you have to think a lot. Which step I should take? What if this step fails? What can I do to come up with the next step? And now we are going to do distal bypass, large arteriotomy on the M2, and choosing which M2 you want to do, most superficial one. And I like to do non-dominant M2. If something goes wrong, I'm not hurting that branch. I'm not hurting the dominant M2. So use the superficial one and elevate them with the gel foams. Now we did the complete, and I'm gonna take the thing, but still there's an air trapped in the graft. So you have to take that air. I made a small hole in the vein and get the air out. Get the air out, and then repair that hole with the 9-0 or 8-0 suture. Everything is doubling nicely. And you'll see now the difference between before and after. That dead branch, see, looks like a dead pale branch. It's not same magnification, but look at that. It become more pink, more red. It's now nicely perfusing. And sorry, I made a mistake. Sorry. And this is the end result. From left STA to the right MCA, Bonnet bypass. It looks very strange, and then you create the duroplasty, cover everything. Cover with the nitrite soaked gel foams, Doppler. And I always Doppler the graft in all bypasses next 24 hours to 48 hours. This is the post-op imaging. Immediate post-op, CT angiogram. Most of the time, I don't do angiograms for these. CT angiogram is good enough. And pre and post-op comparison of the cerebral blood flow, increase perfusion in the watershed areas. And this is the 3D animation of the graft. And he's been symptom-free 3 years. He quit smoking. He promised me after all these hours of surgery. And he still has a mild hemiparesis, which he had long time, and continue to have very robust, you see, very robust bypass. Nice. Still, that tells you, this case tells you everything against those cost study and the bypass studies. There are patients who need bypass for ischemia, okay? So another one, this is the second one I did, same problem. Carotid endarterectomy, then stenting. She occludes her carotid on the left side. Anytime she exercise or go to work, she gets TIAs. And if you look at all the perfusion deficits in the watershed areas, aspirin, Plavix, warfarin, they won't work on these patients, okay? This is a flow phenomenon. This is not an embolic phenomenon. And you see there is no flow in the entire and stenting part, and there is no flow in the common carotid, external carotid, or STA. So again, we found a perfect case for Bonnet bypass, and I'll go fast on this. Bicornal incision, preparing contralateral STA, in this case right STA, dissecting the left sylvian fissure, wide dissection. You take only the small bridging veins, don't take any major veins. Principles set by our pioneers, and I'm sure you have been watching young guys, watching IPE and the other leaders in this platform, doing these surgeries in a way that it is clean, microsurgical or traumatic surgeries, is maximally safe, is not minimally invasive, okay? Forget that word, maximally safe. Again, this is the good case, but in atherosclerotic cases, sometimes you can find this STA atherosclerotic too. See the layers in the STA? When you pierce the vessel wall, you have to get the entire wall. Otherwise, you'll create a dissection plane. These patients tend to dissect because they are severely atherosclerotic. And feel it, back feeling, and create the hole. And do the distal bypass again. I'm moving fast, I'm sorry. And for radial artery or saphenous vein, 10O is too small. Needle won't pierce the saphenous vein or radial artery. You have to use either 8O or 10O. In the neck, sometimes even atherosclerotic patients, you can use 6O, 7O, even 8O won't pierce the atherosclerotic arteries in the neck. Bypass is completed. You go. Doppler. And immediately post-op, she also remains symptom-free for so many years. This is the second Bonnet I did, and very good results. Her saphenous vein remains patent, but is not as robust as the other guy, but still patent. So that means this patient needed bypass, not as bad as the other guy. So but it works. She's only on aspirin, baby aspirin, that's all. She works, she exercises, she can do anything she wants to. Now we are moving to the posterior circulation ischemia. This is even more controversial, right? But actually, in my opinion, posterior circulation ischemia bypass works. I think we need to do more bypass in posterior circulation ischemia. Fadi Charbel and the CEPI, they published recent studies. You know, these patients actually, there's more need for bypass in the posterior circulation cases. So this is one of the examples I did posterior circulation bypass. 72-year-old severely atherosclerotic patient, previous MIs, multiple surgeries, cardiac stenting procedures, presents with the brainstem and cerebellar infarcts. And they kept him flat for 2 weeks. 2 weeks, strict flat, vasopressors to keep the blood pressure 180. And anytime he gets up to sit and eat something, gets severely diaphoretic and dizzy. He cannot sit up and eat anything. So severe perfusion problem. And if you study the case, there's a PCOM, but upper part of the basilar poorly feels from the PCOMs. And left vertebral artery feels from the anterior spinal artery, little bit. And right vertebral artery, there is a high-grade stenosis, and then continues as pica. And if you look at the occipital artery on the right side provides collateral supply to the right occipital lobe. So there are so many challenges to revascularize this patient. Number one, which territory should be vascularized? Should we revascularize the pica territory? Should we revascularize the aica? And if we decide on one, which side, right or left? So I studied this case a lot, and I showed this case in many other platforms. And we always argue with Mike Lawton. Mike has done 7 ICA bypasses. So Mike said he will do ICA bypass in this case, and I said I will do pica. And I think at the end both will work, because you are providing supply to the, even if you do ICA bypass, you're providing supply to the basilar territory and the downward pica territory, or vice versa. So, and then side, which side you need to do, left or right? If you look at carefully, if you do left side, if something goes wrong, if this thrombose, you may have problem with the anterior spinal artery. So you don't want to risk left side, because anterior spinal artery is the only collateral. So you don't want to propagate the clot or something if your graft is thrombose or pica thrombose. Then you're going to have a bigger problem. If you do right side, similar problems, but how to do it? Should I use occipital artery on the right? I cannot, because occipital artery is a collateral supply to the occipital lobe. This patient has severe deficits even supratentorially. So, and then if you do it without occipital artery, how are you going to do this? So after studying, thinking hard, I said I will, this V3 segment looks good. I think we need to do V3 to do pica interposition graft with radial artery. Okay, sounds wonderful, right? Every time we plan something, sounds wonderful. You go there, nothing works. That's why you have to always come up with the A plan, B plan, C plan, even Z plans. So here our proposed treatment. Okay, we need to preserve the occipital artery during exposure, and same time, occipital artery is our backup plan. If something goes wrong, you say, hell, we're gonna rack the occipital lobe, maybe rack the occipital lobe, but at least we revascularize the posterior fossa. So that's what you need to do. And after hours of dissection, as you guys know, occipital artery dissection is not very easy, and you have to plan very well. So this is the showing the problem, okay? This is the complete occlusion on the right, and near complete occlusion on the left. Occipital artery is preserved. Occipital artery itself is very atherosclerotic, but is pulsating and Dopplering nicely. And then we prepared radial artery. We did our far lateral approach and opened the dura. We exposed the V3 and opening the cisterna magna. And soon you'll see the vertebral artery pierces the dura and continues as pica. And it Dopplers fine, but is very low of Dopplering. So it's perfusion issue again. And you see vertebral artery continues as pica. You see the posterior spinal artery here. And we prepared the radial artery graft, adventisectomy. So long arteriotomy, and everything filling nicely, Dopplering, this proximal pica, distal anastomosis is done. So far we are happy, everything looks good. And we make the arteriotomy on the V3. I open. I underestimate the atherosclerotic disease. So there was a plaque in the V3 segment, which angio didn't show clearly. So I did the endarterectomy, and my heart started getting pounding, because I knew anytime you do in the artery is high risk for thrombosis. And that's what you do. See, it's not filling. This cobra head should feel like this. It's not filling. And I'm very nervous, and it's not Dopplering. See, Dopplers here feels nicely. It is not filling. And this was retrogradely filling after the distal bypass. That means proximal bypass is the problem. Nothing here, see? So now I have a problem. What am I going to do? So I cut it. As soon as I cut, bypass fills retrogradely from the pica. See, that was the problem. So that atherosclerotic disease and endarterectomy created the thrombogenesis in the proximal bypass. See, nice backflow. So problem is it was the proximal bypass. Now I am finding an occipital artery, my backup. See the atherosclerosis? It's not even hardly bleeding. So I need to go to the proximal occipital artery, and there's little size mismatch, but that's okay. Now I have to do occipital artery, radial artery interposition graft to the pica. This is my resurrection plan, and we do that. we have to salvage the situation, and that's why I am taking risk to the occipital lobe. But what can I do? Right? Take it. Bypass feels nicely. See distally. And this is the proximal vertebral artery. This is occluded part. It starts from here. It's good and feels nicely, and he remained asymptomatic for 1.5 years. Eventually, he died from a heart attack, but he lived 1.5 years, very good life, and he was very happy. See, in 1 week, he was up walking. This guy remained in the bed 2 weeks, 2 weeks. So what about iatrogenic injuries, right? This is the outside hospital. Patient had tuberculosis meningioma, multiple surgeries, radiation. He comes back with the recurrence. Neurosurgeons took him back to the operating room. While they are doing the surgery, brisk bleeding from the tumor. They don't know what to do. Put gel foams and close the case. And they do angio. Angio shows a small iatrogenic injury, pseudotumor, pseudoaneurysm, and also occlusion of the A1, and strokes in the basal frontal region, and still tumor. And now we have a traumatic aneurysm. How to treat? Covered stents or bypass trapping. Never try to clip traumatic aneurysms, okay? Don't even attempt it. It's gonna blow at your face and you're gonna be in trouble. So you have to have a definitive plan. And I don't think covered stents are the definitive answer for these. I think bypass is the way to go. And this is what we did. Bypass, trapping, see, robust radial artery graft. Post-op day 3, he was having the diabetes insipidus. We treated all these. See, post-op 2 months, and remains without any symptoms over 4 years. He's mentally is little off from his surgeries before, and nothing else I can do. But this is a definitive problem for iatrogenic injuries. And you will have iatrogenic injuries like the one I show in my introduction slide. This is a Hunt and Hess grade 3 ruptured ACAM aneurysm, clipped successfully by one of my partners, and patient develops vasospasm and multiple attempts of angioplasty, doesn't improve, and then this is what happens. Okay, nice clipping of the ACAM, beautiful post-clipping vasospasm. And when they are inflating the balloon, sudden extravasation of the vessel. So who's going to repair this? Endovascularly? How are you going to repair? You're going to put the balloon and occlude the artery. You're going to take entire MCA territory. Okay? Better options. Either you're going to do immediate bypass, which may take several hours. You are not prepared. Or just explore direct repair if you can. While you are exploring, somebody harvests the artery or a vein from the leg. Okay? And he was ready to take this, interventionist was ready to take this artery. I said, don't take it. Put temporary balloon occlusion, let the bleeding stop, and move to the OR. I'll start driving, okay? And that's what we did. It was very chaotic environment, but they couldn't record the entire video because of that chaotic environment. Everybody's trying to do something to save the patient. And when I get there, my partner opened the head and I explore. First, I put the temporary clip on the ICA and I explored the M1. Right distal M1, there was a tear. I put 3 tenor sutures, you can see here. And then did the ICG green. So nice capillary filling, everything is filling nicely. We are done. We repaired the problem and patient did well, believe or not. So who's going to do this? Hybrid neurosurgeons or us? Or should we call plastic surgeons in the future? If we don't keep doing these surgeries, who's going to do this in the future? Okay, and this is my complication, okay? Nice lady with the swallowing difficulties, foramen magnum meningioma. Okay, I am doing this case, very firm foramen magnum meningioma. I cranked the CUSA going, and if you go back, I did the CT angiogram. You see, vertebral artery was encased by the tumor. And I knew that. And other word is codominant. And I did the far lateral approach, exposed the vertebral artery, B3 segment extradurally. I have a proximal control. In my mind, I know what to do. Proximal control, then distal control, and then go find the artery. If you can dissect, dissect. If you cannot, leave the tumor on the artery, right? This is the plan. This is everybody will do. But, you know, sometimes distraction in the OR is not a good thing. At this stage, I am CUSAing, and the junior resident comes to the operating room, and I'm operating. I was doing this case with the chief resident, and it starts talking to the chief resident about a traumatic epidural hematoma who needs emergency surgery, herniating in the ER. And I'm not on call. I have nothing to do with that case. But I start listening that case. I start getting curious about what they're going to do about that case, how the residents are going to manage that case. And the chief resident step aside and talking with the junior resident. I'm completely distracted. Okay, you guys know, yes, I live in the United States, but originally I am Turkish, and Turks are easily distractible people. Okay, so don't distract the Turks. So go. I'm listening that, and I said I forgot about the word. I forgot about encasement and anything else. Then 10 seconds, all you need to run into trouble. Okay, this is what happens. So OR, operating room, operating theater is not the place for distraction, listening music, or operating room is the place to meditate. Okay, meditation is our surgery. I'm sure, I mean, you guys read every day IPE's messages, right? That's what he's trying to tell you guys. This is neurosurgery, okay? This is our meditation. This is our profession, okay? We love this. But I'm lucky, just stops there. And now I am doing what I was supposed to do before. I found the distal. I have a proximal control extradurally. And I don't, it's codominant, but I don't want to take this word. You know why? You take this word, if there's no perforators and on the front aspect, nothing will happen. But if there's perforators, and there are usually, especially the posterior spinal artery, then you are screwed. You cannot do that. So you can repair though, two bypasses, I mean, 2 clips, temporary clips, and 3 teno sutures. Yes, it's stenotic, but it's patent. Okay, and then you finish the tumor. So you don't want to run this problem. Don't get distracted, number 1. Okay, operating room is a very, very sacred place. And don't get distracted. And also, to prevent these problems, proximal control in tumor surgeries and distal control. Okay, and stay away from the arteries until you have those controls. But you can do it, and you will have these complications. These complications shouldn't scare you, should make you better. Okay, so now we are coming to do complex aneurysms and giant aneurysms. Okay, I'm sorry, I'm taking too much time, but I can't stop talking. Okay, so what about this one? 62-year-old progressive vision loss. She can only count fingers from this distance. good light perception, but that's all. For 6 months, and we have this giant aneurysm measured 2.6 centimeter. And it seems like involving the supraclinoid ICA and almost fusiform appearance, at least 270-degree involvement of the artery wall. So there's no good neck. And I discussed the options with her, and she want to go ahead with the flow of diversion. I'm okay with it. But the moment I look at the dynamic angios runs, I know that they won't be able to. I'm not angiologist. I'm not hybrid neurosurgeon. I knew they cannot put the stent, anchor the stent there, but they tried. They tried 2 separate sessions, each 12 hours, total 24 hours, 3 outstanding, wonderful interventionalists, endovascular surgeons. They couldn't anchor the stent. And patient got upset, blah, blah, blah. And now we are back to where we were. So what should we do? And this is my writing in our ICU screen, explaining her the situations when she came first time. Coiling is not possible, and it's going to cause more compression. Clipping, I don't think it's possible. It's fusiform nature. And you need bypass. Okay? That's what we need to do. And how? You need, she has no good collaterals from the contralateral side or PCOM, no symmetric venous phase. So she needs a high flow, so-called high flow bypass, and with radial artery. Okay? That's what we plan. But I always have backup plans. Backup plan here, if something happens to radial artery, I have to have a superficial temporal arteries exposed and preserved. And that's what we did. And preserving the superficial temporal arteries, then going to the Sylvian fissure. Wide fissure dissection in these MCA bypasses, not the M4, M3 bypasses, but the N2 bypasses. And we got the glimpse of the aneurysm, 2 branches of the MCA. I will go for non-dominant one, although this is more superficial, because I don't wanna mess up with this one. Pediatric chest tube for suprazygomatic superficial soft tissue, and tunneling and getting the graft, and again marking the graft so there's no twisting of the graft, especially when you tunnel in the under the skin here. Good adventectomy, same principles, and arteriotomy, bypass. Distal bypass first, anchoring sutures. Okay, nice backflow. Distal bypass is done. We're gonna go for the proximal bypass. She has very high ICA bifurcation in the neck. So external, normally I will do external carotid artery bypass, but because of the high bifurcation, you can do the common. And for common bypasses, I learned from the vascular colleagues to use a aortic punch, and there are different sizes of the aortic punches. So you first make the arteriotomy, and this patient is atherosclerotic all over. You'll see there's atherosclerotic plaque, and this is the aortic punch. It makes a very nice cut, you see, but still there's a plaque there. I want to clean that, and I want to have an elliptic shape of the arteriotomy. And again, I would like to emphasize this point one more time. If you have this kind of atherosclerotic vessels, you have to pierce all layers. So you don't want to pierce only one layer, superficial layer, then you create a dissection plane. And this is an 8-0 suture. If that doesn't work, you may have to use the 7-0 or 6-0 sometimes and finish that. That works. Now we are done with the bypass. We put the clip to the ICA, remove the other clips, So bypass is operational now, functional. Everything is filling nicely. So what we're going to do now, we are putting a clip on the internal carotid artery in the neck. So we don't want the bypass get occluded while I am trapping the aneurysm. Okay, so that's why you need a demand. So I put the temporary clip in the neck so bypass can be functional. So now I'm going for extradural craniotomy. I know showing you guys beautiful dissection of this region, paraclinoidal region, paracellular space. I like to do extradural craniotomy unless there is a specific reason for doing it intradurally. And that's this, I'm going to skip this, and another time I can show other videos for tumors and optic unroofing, craniotomy. Why am I doing craniotomy? Aneurysm is huge, and I want to do trapping distal to the ophthalmic artery. I don't want to take risking of ophthalmic artery. So, and I want to create this nice space. Without craniotomy, this space is not available. Now I put the permanent clip in the supraclinoid ICA distal to the ophthalmic. I am taking the clips from the internal carotid artery in the neck. So I'm moving back. Now I need to explore aneurysm. I need to explore PCOM and anterior choroidal artery. I need to trap this aneurysm completely from all three. First, PCOM. So you see, and I have to put the clip, is luckily is not fetal configuration, and the clip distal to the perforators, and perforators should fill from the PCA, and clipping the supraclinoid ICA proximal to the choroidal artery. So I'm preserving the choroidal artery flow, which is coming from the bypass. And now I need to decompress the aneurysm. It seems like not decompressible with the suction aspiration. I open, there's a trapped blood there because she had the visual problems. I need this decompression, and that's all you need to do, okay? You see all the choroidal is filling, PCOM filling from the PCA, and bypass is filling the entire MCA territory. But we are done. We trap. And this is her. Post-angio, looks nice. That's all you need to do. And another case like this, this case also flow diverting stent attempts multiple times. There's a thrombus centrally. If you have a central thrombus, you cannot decompress the aneurysm, do thromboendarterectomy and clip reconstruction. You don't have time. Anytime you open the artery, you're gonna get bleeding. So don't attempt to reconstruct, clip these aneurysms, just do the bypass, and that's what we did. And you see the bypass filling nicely, and he's been doing very well with this bypass for so many years. And fusiform aneurysm, same problem. Fusiform aneurysm, flow diverting stents. If you can, if you cannot, we have options. We are microsurgeons, right? So this is a young boy with this partially thrombosed proximal pericallosal artery aneurysm. You see the one pericallosal artery comes left, and then there's this gigantic aneurysm and continues. And this is the contralateral pericallosal artery. So this artery is very small. Maybe this was etiology was a dissection. We don't know, but you need to do something. And what are the options we have? We have distally. You can do A3 bypass, right? Trapping, flow diverting is not possible. You can do just simple trapping. This is pericallosal artery, but our colleagues studied this well. There is no good filling from the posterior pericallosal. So that tells you simple trapping won't work, but you need to confirm that at surgery with direct clipping. If there's a good backflow simultaneous, you can do it. And so we need exploration, okay? So options, first, all the distance doesn't look good. Here, A3 bypass, which will be the simplest, easiest solution. If distance is too far away from each other, you can do interposition graft, STA to A3, then trapping. Okay, or saphenous vein. So you have to prepare all these options, okay? And this is what we did. First, find the STA trunk. And so you have to have an interhemispheric exposure as well as the transsylvian subfrontal exposure. You can get to the proximal A2, proximal to the aneurysm. And as soon as we explore, we notice that both A3s apart from each other. And even with the wide dissection, I couldn't bring them together. So A3, soon we realized is not a good option. And now what am I going to do? I'm going to do a test occlusion of the A3 and run the ICG green and find out that can I trap it. So now I'm doing it. See, flow is very small, very delayed. So he's not going to fly with the just simple trapping. He needs a bypass. We established that too. We established the only thing we couldn't is the length of the radial artery graft. And I did that and measured a million times, and the plastic surgeons are simultaneously harvesting the radial artery now. They just started at this point, and now I'm exploring the proximal part of the aneurysm. And this is A1. And see the olfactory tract here, interhemispheric fissure here. And I'm going to find the suctioning the little bit gyrus rectus, and I'm finding the pericallosal artery proximal to the aneurysm. Now I can do bypass and trapping. So I prepare the A3. We have a radial artery. We marked it, and soon you'll see we realize that there are holes and the tears in the radial artery. Here we go again. We have problems, okay? And this is not my cut, okay? This is cut during the prepping. So I need to repair that first. And there were some other two smaller holes here. I repaired that too, because I don't want to go do another harvesting from the leg, right? So we prepare that, we prepare this. Always you're gonna face to the obstacles during surgery, but you need to know how to overcome those, and you need to develop skills and the experience in the lab to overcome those, okay? And look around the other disciplines, what they do. So now the distal bypass is done. Nice backfilling, okay? This is exactly what we need, but when we measure the graft is too short. So now I have another difficulty. Okay, they told me they harvested 18 centimeter, is actually 13 centimeters. So now instead of STA trunk, I am going to the frontal branch, because then I can overcome to the gap. But that creates a big size mismatch, and I'm overcoming that size mismatch by making the oblique cut here and making the radial artery graft smaller. And I used dilators also, but that didn't work. And now overcome to size mismatch, I oblique cut and suturing. And end-to-end anastomosis. It looks, I was supposed to do here, but it's too short. So that drawing also explains why. And now proximal clipping and distal clipping and trapping the aneurysm. ICG green, bypass is nicely filling. You see there's that arteriotomy repair side. If there's a demand, bypass will work, okay? And see, aneurysm is gone, and most importantly, bypass. This is the interposition graft, radial artery from the frontal branch of the STA to the A3, and ACA territory is nicely filling. And he's been actually more than 6 months now, almost a year. He's been doing very well. He's back to school. You see the branches going here, and you see the A3 is nicely filling. This is the radial artery graft. Radial artery graft here. Okay. And this is very recent case. I'm sorry, I'm taking too much time. I apologize a million times, but I need to show this. This is the only time I can show. So this is a Hunt and Hess grade 5 subarachnoid hemorrhage from a dissecting aneurysm of the pica. Okay. We put the ventricle. He was coded. He had a respiratory arrest. We brought him back. We did the angio. He's morbidly obese, and the options: do nothing. He's Hunt Hess grade 5. Let him go. Declare. Nature declares whatever is going to happen to him, or endovascularly try to put a stent here. But if you do that, it's not definitive. He has to be on the aspirin and Plavix, and we don't know what's going to happen. There are good results and there are bad results with the Elvis Jr. or any kind of small stents. Or you just take the pica, give him a good posterior fossa stroke, and see whatever is going to happen. Okay, so I don't start the game by accepting the defeat. Okay, all these options are defeat to me. Okay, you are starting the game to lose the game. Okay, we don't do that. So we do surgical options. If I need to trap, I can trap surgically, short segment, and I can test it. Okay, and I can be more precise when I need to trap. Or I can do pica bypass. I can do occipital artery pica bypass. I can do V3 pica bypass with radial artery. I can do V3 pica bypass with saphenous vein and trapping. But if you look at these images, he has a very steep posterior fossa. His posterior fossa. Can you guys see this image, sagittal image?
Yes.
It's very steep. And look at the thickness of the bone and the nuchal bone. It's huge. So, and look at the picas, so high. Tonsillar loop, you need to do pica side-to-side bypass. It's too high. So these are the obstacles we encountered, and we knew this. We knew before surgery. So you come here. Okay, there is no way I can do pica bypass because of the steep angle, also because of the very high tonsillar loops. And you'll see even doing the unilateral bypass, exposing the one loop is going to be very difficult. I need to excise, resect tonsillar loop, tonsil. So you don't see any, barely with retraction, I'm getting the pica, but there's not enough space with even with the retractor. So I need to resect so I can get my hand to suture. So I'm resecting the tonsil. And that's why I decide not to do side to side. It will be impossible to do even if I resect both tonsils. Okay. So now I isolated after extensive resection of the tonsil, pica loop, and swollen brain this is a Hunt and Hess grade 5. And this is the radial artery graft. Sorry. And there's another obstacle. During the harvest of the radial artery, everything was going well, and the plastic surgery team tells me, oh, suddenly radial artery thrombose. What are we going to do now? But luckily, they had a cephalic vein here. I said, harvest cephalic vein. I don't need long graft. I need graft enough from the V3 to pica. So they harvest the cephalic vein, this vein, and this is the thrombosed radial artery. Okay. And then we did the distal and proximal bypasses, huge cephalic vein, see? So there's a kinking here. You need to prevent that with the gel foams. I corrected that. Nicely filling graft from vertebral artery to the pica with the cephalic vein after hours of dissection. And believe or not, this is done on Saturday. And see, there was 23 people in the operating room watching this surgery. seeing how I struggle, tearing, sweating, okay, crying. Why this happened? Why this happened? Why this happened? But you need to come up with this plan so you overcome. At the end, victory is ours, okay? Nice bypass, flow, everything is flowing. See how big, robust artery. We trapped pica from here to here, brainstem perforators here, and there's one perforator here, all preserved. He start coming out. He required tracheostomy, peg tube placement, but start waking up. Everything is discontinued. As this is 5 months picture, he start traveling. Even now, he's doing much better. Okay, his MRSA score is 2, and it's gonna in 1 year, it's gonna be 1. This patient will live normal. Okay. And mycotic aneurysms can be done. Don't take these arteries. Okay, you can do inside to bypass in some of these. Look at this one. Okay, submillimetric arteries, grade 4 subarachnoid hemorrhage. You see, M3 comes, gives 2 branches, very small. So I did bypass here, inside to bypass. This vessel measures like 0.7 millimeter, and another branch running parallel to this branch. And after finishing that, you'll see very small artery, nice filling. Then I get the other branch, cut, remove. This is the mycotic aneurysm. You can watch this entire video in 3D. And now I'm going to do end-to-end inside to here. So 2 small bypasses. Feels. And she made excellent recovery. But at 9 months, she had endocarditis. She had another stroke. She's still doing fine. And finally, I convinced cardiac surgeons to treat her with surgery. So traumatic aneurysms, again, gunshot wound to the head, self-inflicted, a young boy with the juvenile rheumatoid arthritis. And you can do double barrel bypass. You see, it works. Blister aneurysms. This is the case I showed you in the introduction, okay? Case, blister aneurysm, unrecognized. It is blister, it's dorsal wall, content is grade 4, improves to grade 4 after ventric. They coil, okay? Very nice coiling. In day 15, you don't see any aneurysm here, see? But when they are coiling, they realize coils go to the dome very easily, and they stop there. At that time, they woke up. They say, this is not a true saccular aneurysm. And if you look at the location, it's dorsal wall. This is typical location for blister aneurysms. There is no wall of the aneurysm in blister aneurysms. Blister doesn't describe the size, describe the pathology, okay? These are like the traumatic pseudoaneurysm. There is no adventitia, nothing there. If you try to put coils, it's gonna blow. Luckily it didn't blow, but in day 15, we repeat the angio because we want him to get over the vasospasm period. Aneurysm is this. It's huge pseudoaneurysm. What are we gonna do now? This is what we're gonna do. I explore like this introduction slide. What's gonna happen now? Nothing, right? First you need to stay calm. And you need to be prepared, not unprepared, okay? And this is, in reality, this is what we did. Actually, I have already done the external curve to M2 bypass. I was exploring and I didn't do anything. See, this is happening. This is the real time and very old video. So now I have a bypass. I don't care. Bleeding occurs, and it shows how dangerous these aneurysms. Spontaneously bleeding intraoperatively. Before, I didn't even touch the aneurysm. So you just go, remove the previous coils, trap the aneurysm, bypass is filling nicely. That's all you need to do, okay? Good bypass. Post-op 1 year. He's been with us for 15 years, doing very well. Another Another blister aneurysm. Not every blister aneurysms are same, okay? Some has no wall at all. Some has very little area that's a defect. So those aneurysms you can explore, but you have to do prophylactic bypass or do the bypass and if necessary, trap the aneurysm later. So this is the small M3 branch. I am doing prophylactic bypass. And I did the bypass, then I'm gonna explore the aneurysm, see, can I trap it or can I reconstruct? See, this aneurysm is different from the previous one. This is the aneurysm here. So these ones repairable, but you don't know until you get there. So PCOM origin, and I need to find the distal. And after final discussions, I put the clip in a way that, see this way. So this is a subarachnoid hemorrhage case. I don't want to trap unless it's really, really necessary. I want to constrict the ICA, but not trap it. And that's what we did, where we stenosed the ICA, kept the flow, but we have a bypass. And if necessary, I can do the second bypass, double barrel. Okay. See, stenosed and nice filling. Bypass is filling, and he did very well. So I'm going to stop here. In conclusion, each patient you need to assess individually. There's no algorithm in these surgeries, okay? Algorithm is taking care of the business, taking good care of the patient, and doing best for the patient. When limited available conduit options, you should be versatile. You should be watching your colleagues, head and neck surgeons, plastic surgeons, cardiovascular surgeons, and be aware what they do. They have more experience than us in this field, okay? In the vascular anastomosis. And anytime you go do anything, you have to have a multiple backup plans. You cannot just go there with the one, oh, it's going to be perfect. Nothing is going to be perfect, okay? Sometimes we have the shitty situations and you need to find a solution for that. And mental preparation is the most important part of these surgeries, okay? You have to be mentally prepared and study each step you're going to take during that particular case. And go to the lab, okay? Go to the lab, study these simulation methods, fake vessels, rat arteries, rabbit arteries, whatever you can do, okay? And don't forget this, cerebrovascular open surgery, endovascular surgery, you cannot compare, okay? This is almost like comparing apple to the orange. They are complementary to each other. Work closely, do your stuff, and help the endovascular colleagues and get help from them if you need them, okay? And you need to be versatile. You need to have a thorough anatomical knowledge and thorough understanding of these complex problems. And please come and visit us. Without lab, without dissections, you are nothing. This is our lab here at the University of Wisconsin. And like Confucius said, I hear, I forget, I see, I remember, I do, I understand. Read, listen, watch, dissect, go watch the masters, listen them, do your best to devote your time to the microsurgery, okay? Microsurgery is a sacred discipline. And so far I have like more than 230 fellow students, neurosurgeons all over the world. We have 2 courses every year. In May, we do our skull-based course, and in fall, we do microsurgery bypass course. Unfortunately, this May we had to cancel due to the COVID. And these are my fellows. I'd like to thank Sima for preparation of this talk. My current fellows, Burak and Walid, Ufuk, and we get all people from all over the world. And I thank you for listening me carefully. And I apologize for taking too much time. Any questions, any comments, I'm happy to take.
Mustafa?
Yes,
Yeah, excellent presentation, Mustafa. Very good. Excellent. Yeah, one of the best presentations that we have heard on this forum. So thank you very much. We look forward to more of your presentations. We are very happy to have you here. And well, let's plan for more presentations again. Let's see how it goes. And very glad to have you on board.
Definitely. Thank you very much. And thank you for creating this wonderful platform. Please keep doing it. And I promise I will do more presentations.
Yes, Mustafa. Looking forward to that. Now, I think we can allow about 5 questions. 5 questions for you. And then after that, is Professor Goyal around?
I believe he is. Atul, are you there? Perhaps he stepped away. I'll try to get a hold of him.
He's not around?
But, apparently he's not answering, but why don't you go ahead with the questions and I'll track him down.
Sure. Let's go ahead with the question, please. Any questions? Yes, Saif, please ask.
Go ahead, unmute and ask.
Well, somebody is asking, do we need flow measurements for all bypass operations?
If you have it, it's good to have and measure the flow, and especially the cut flow index introduced by Fadi Charbel and Seppi. Believe or not, I don't have Charbel probe in my hospital. I have a micro probe, and they are really reluctant to get one more. And even in the United States, sometimes we face these kind of problems. So I don't have a cut flow. I cannot measure the flow intraoperatively. But once you establish that patient needs bypass, and with angiographic, perfusion, and clinical findings, I think you'll still do good with choosing your bypass. I don't think you need to have it's not absolute to have the flow measurement.
John, Atul is here. Professor
Yes.
Goyal is here. Please, can you please connect him on? Please, can you put him into the panel, please?
Yeah,
And
he's
there's
in the-
there's one more question from Saif. And can you see that question, John? Can Professor Baskaya please go over again what he did when there was a mismatch in length in the graft? Well, I think he went for the frontal branch. That's what he did. I mean,
Yeah.
Mustafa, can you just...
So what I did is, let me share the screen one more time. So you see here, this is the radial artery. This is the
Mustafa, you're not sharing the screen. I mean, you need to share the screen.
okay. Oh,
On the bottom half, you will find something called shared screen. Can you see that? On the bottom part, you just move your mouse there. And then on the bottom part, you will see something called share your screen. Maybe you should go to the zoom icon. Maybe you are not seeing, you go to the zoom icon, press the zoom icon. And then you will see on the bottom half, you will see a share your screen.
I did it. Sorry, I'm very sorry.
No, don't worry about it. I mean,
okay, share screen.
Yes.
That's it. There you go.
It's shared.
So you see here, this is the size mismatch. Okay, this was my radial artery. This is a frontal branch. So there were 2 problems in this particular case. One is the radial artery turned out to be very short. And second one is once I isolated, instead of superficial artery trunk, I had to isolate the frontal branch of the superficial temporal artery. And that is smaller artery, and that created a size mismatch, okay? In order to overcome this size mismatch, I cut the radial artery obliquely, and then I suture to put 2 sutures onto this oblique cut and make the artery smaller, so I can overcome the size mismatch. And this technique, we call it tapering technique, and it's published in another bypass case and World Neurosurgery. There's a video, and this case itself, and then the other series of bypasses we just recently submitted for publication. I'm hoping it will get accepted so we can publish it. So this is how I overcome. There are other techniques you can overcome, but those you can do fish mounting in both arteries for end-to-end anastomosis, but it's not possible to do if there's a significant size mismatch. Whatever you do is you cannot overcome. Did I explain okay?
Yes. Excellent. Very good. I mean, I'm sure he understood that.
Any other questions?
Hello.
Do you see that last question?
Hello?
Go ahead. Go ahead.
Hello. Do
What?
you hear me?
I don't think that connection is going to work. Go ahead. You may have to type your question. I don't
Very
think-
much for this fantastic lecture. Thank you very much for this excellent lecture.
You're welcome.
Professor, can we do these techniques for some cases of carotidocavernous fistula? Can we, Professor, do these techniques for some cases of carotidocavernous fistulas?
No, my friend. These you don't need bypass for CC fistulas unless there is a very, very specific case. You need to create something. I think is the treatment for CC fistula, either endovascular or open surgery, and you can obliterate those fistulas successfully without bypass.
Yeah, the answer to that question is yeah, well, what Mustafa told. Obviously, it's a communication between the carotid and the cavernous sinus. There's no role for a bypass there, you see. I mean, I understand that you probably don't understand the pathology there. So there you either do, I mean, of course, in Nepal, and we often open, last time we showed you how we opened the cavernous sinus, and then we put in the muscle, or we put a clip there. So we showed you that last time. So that is exactly what we do for a keratoconus fistula. There is no role for a bypass there. So excellent presentation once more, Mustafa. You are a very good teacher as well. So you're an excellent teacher. Thank you so much. And we will now go on to, I hope you remain here, and we go on to Professor Goyal. I hope he is connected. John, is he connected?
Yes, he is.
Dear John,
Yes,
and
Mustafa.
dear Ipe, I have in 20 minutes, I have another webinar set for today.
Oh, sure.
Okay.
Please pay my respects to Atul, good friend, Dr. Atul Goyal. And again, I thank you very, very much for organizing this and leading this wonderful platform. Thank you, thank you, thank you.
Thank you, Mustafa.
you.
Mustafa.
Hey,
Mustafa, can you hear me?
I hear you.
That was a wonderful presentation, Mustafa. And I would like to see more of you and much more of you.
Oh, thank you very much.
Anyway, any case, I want to say to the young people sitting here that nobody reaches any kind of level without very hard work, persistently hard work, dedicated and focused work. And you have shown that in no uncertain ways. Mustafa, congratulations to you for your work. And
Thank you
best
very much.
wishes.
Thank you very much. My best wishes to you and your family, and please stay safe and be well. And always love to hear your talks. And I learn a lot from you, and I'm hoping to learn more. Sorry, I will be missing your talk because I have another webinar.
No problem.
Please, all you guys have a wonderful day. Okay, stay
Thank
safe
you.
and be well. Thank you very much. Thank you.
Bye-bye. Bye-bye.
Bye-bye.
Bye-bye.
Over to Professor Goyal for his talk now. Good evening, sir.
Good evening, Ipe. Ipe, are you with me now? Ipe?
Yes, 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 I
Do
can
you
see
see
you,
my
sir.
slide? Yeah.
Yes,
Yes.
yes.
So in the series of skull-based tumors and complex tumors, I will still call foramen magnum lesions or foramen magnum tumors complex. The issue of surgical approach and surgical approach selection is very important. Understanding the foramen magnum is very important. In the last several years of my life with foramen magnum, there is no question that I have matured in my understanding of this region. And I want to take you to the journey with foramen magnum problems. So craniovertebral region is surrounded by a very complex group of strong muscles. And if you see from behind, this is from behind and this is from front. The entire bulk of muscles connecting the head to the neck are behind. And the most important bulk on the nape of the neck is one of the strongest group of muscles of the whole body. There are no muscles as strong as the nape of neck muscles. Do you know which is the next muscle, which is the strongest muscle? The strongest muscle is the gluteus maximus, the other one. And do you know which is the other strongest muscle of the body? I want you to, young people, to guess, but I will tell you the strongest muscle of the body is the uterine muscle when the pregnancy is completed. And the uterine muscle, the strength of the uterine muscle, no other muscle in the body can compare. It just pushes the baby out of the womb, uterine muscle. So these are the strongest muscle of the body in life, other than pregnant female's life. And you see the muscles located in front of the foramen magnum are quite flimsy and thin. And this is the anterior C1, C2 articulation that you can see. You just make a small incision and you are on the articulation from front. So to expose the region of foramen magnum from front may be an option, and it was quite an option some years ago. And this is the suboccipital triangle, which can expose the vertebral artery, various muscles in the triangle. This is the C1 arch. And we have to know the anatomy of this region very well to do any kind of foramen magnum work. And this is the beautiful dissection which I got from the internet, but my resident, one of my residents has done some remarkable dissection in this area with these kind of arterial dissection and venous injection. So if you see the arch of Atlas here, the vertebral artery comes over the arch of Atlas in this area. Posterior arch, the vertebral artery has quite an intimate relation in the posterior arch of Atlas, and then it goes into the foramen magnum in front of the tonsil and brainstem. So these two structures, the artery goes right in front. And here lies the occipital condyle. So it turns around the occipital condyle and then it goes intracranial in front of the brainstem. And here there is quite a loop of the artery which is above the arch of the Atlas. And as I have shown you earlier, this dissection, the vertebral artery goes inside. So this, of course, is a very rare kind of a situation, but it comes out of the C2 foramen and then goes here like that loop and then goes above the arch of Atlas. So this is above the arch of Atlas and this is outside the C2 foramen and this is so here if you see the artery goes like that The artery loop may go inside the C2 facet, and this relationship also we must remember if we are going to do transoral surgery for this area. And the loop goes like that. And as I mentioned to you, this is a dynamic phenomena. The artery goes up and down, and then it comes outside the C2 foramen. And then there is a loop of artery between the C1 foramen and C2 foramen, and it goes inside the C1 foramen and then makes a loop over the arch of atlas. So this is that same dissection. Now, if you see this dissection, this is a anatomical line drawing, and I see quite a, this artery does not go straight like that. It goes down into the loop and loops inside the C2 facet, then comes outside the C2 foramen, and then goes up, and then comes out of the C1 foramen over the arch of atlas, and then it goes anterior to the brainstem. So foramen magnum is surrounded anteriorly by very large occipital condyles. And these occipital condyles can interfere in your exposure of lesions which are located anterior to the brainstem. So quite a bit of foramen magnum is formed by the condyles, and then the rest of it is formed by the foramen magnum or the suboccipital bone. So this is the condyle, and this is the lower cranial nerves. From the condyle, hypoglossal nerve goes through the condyle, and above the condyle are the lower cranial nerves. And this is the 9th cranial nerve. This is the brainstem here. This is the condyle. The hypoglossal nerves are not seen here. Hypoglossal nerves go through the condyle and divides the condyle into two parts. Sometimes there are two grooves for the hypoglossal nerve. They have two foramina, and then they combine either inside the condyle or outside the condyle. This is the lower cranial nerve 9th, which has component which comes from the cervical spine. And then these are the 9th, 10th, 11th cranial nerves. This is the 11th cranial nerve, the cranial accessory and spinal accessory nerve. So there are various tumors located in the foramen, in the region of foramen magnum, and I will take you through some of these tumors. So one is meningioma, as we all know, and we will discuss this. And if possible, I'll show you some videos. C2 neurinomas are also in the region of foramen magnum, endodermal cyst, retroodontoid pseudotumor, and infective lesions sometimes. So this is my old cover page of my book, which I had shown you earlier. And in this, my exposure to the entire skull base was very aggressive, and early part of my exposure for foramen magnum lesions. Other thing that I would like to show you in this diagram is not there. There are dentate ligament also, which is very important component of this area when you are coming from the cervical spine. And dentate ligament you have to cut to expose the part in front of the brainstem. So dentate ligament, and you should not mistake it with the cranial or spinal accessory nerves. So you see this is a beautiful lower cranial nerve chamber in just above the condyle, and here will come the jugular foramen and jugular venous complex. So earlier in my 20 years, if I have spent 38 years in my neurosurgery, 16 years maybe with very aggressive exposures, and further 16 years with minimized exposure. So this is one lesion. I will like the young people to guess what is this lesion. And during early part in 1992, 93, if you read these papers, these were called pseudotumors. And these were considered one very good option for transoral surgery. And then there was an option for lateral exposure for these kind of tumors. These were pseudotumors. And these are quite not very common, but they are known tumors. Then we described that these are not tumors, but they are secondary like osteophytes, and they are associated with atlantoaxial instability, and they will regress spontaneously. There is no need to do any kind of surgery for these tumors, and there is atlantoaxial fixation is the treatment. So long time ago, I described for the first time in the literature that these are not actually tumors, which was a very common entity at that time, pseudotumor, and there were many other names for this tumor. And Professor Alan Crockett had described transoral surgery for this, and subsequently lateral exposures and lateral surgery were described, but atlantoaxial fixation is the treatment for this. And this was my first article at least 20 years ago, where we had described that retroodontoid mass is a manifestation of atlantoaxial instability, and these need not be removed. They spontaneously regress. You treat atlantoaxial instability, and there is no need to handle these treatments, these tumors. So you must know these tumors. Other thing that we described for the first time in the literature, that these cysts behind the odontoid process, you may confuse them with arachnoid cysts and other kinds of cysts, and you will say that these are very simple lesions to operate. Why not just come and remove this cyst? But if you realize that there is assimilation of atlas in this case, and there is a facetal instability in this case, and there is no need to touch this cyst. I did this fixation, and the cyst disappeared in the immediate postoperative phase. I did within 1 week of surgery, I did this MRI, and I did not even touch this cyst. So you must know that some of these cysts, I'm not saying all of these cysts, but some of these cysts are associated with atlantoaxial instability, and atlantoaxial stabilization is the treatment, and this cyst may disappear, not may, will certainly disappear. So you have to know what are the indicators of an unstable spine. Assimilation of atlas is by itself an indicator of an unstable atlantoaxial joint. Facetal instability is another indicator. And also during operation, you can manual manipulation of bones can give you information about unstable atlantoaxial joint, and this cyst need not be removed. This is another cyst. You see here, there is another cyst. There is os odontoideum in this case, clear manifestation of atlantoaxial instability. No need to touch this cyst. There is clear-cut and unstable atlantoaxial joint. You do atlantoaxial stabilization, you see the cyst has gone. So there is a very important message for the panelists here, that all cysts are not tumors, and all cysts are not to be removed, and compression is not the treatment for these kind of cysts. Atlantoaxial, when you have to see the manifestations of atlantoaxial instability, and stabilization is the treatment, and this cyst will automatically disappear. So retroodontoid pseudotumor and retroodontoid cyst. So retroodontoid mass can be an evidence of craniovertebral junction instability, and it can suggest the need for atlantoaxial stabilization without the need for touching the cyst directly. Now, this is another most beautiful case which I'm showing you. I must tell you that 20 years ago, this is a rheumatoid case, and this is a retroodontoid pannus. So pannus was considered to be a primary issue, and pannus was considered to be a compressive factor of the craniovertebral cord. So, and transoral surgery and lateral surgery and things like that were considered to remove this pannus. And this was a very common form of treatment. And transoral surgery, actually the main indication for transoral surgery during 20 years ago was to remove this pannus. But you see there is an unstable atlantoaxial joint here. And this was treated by me several years ago by joint jamming technique. And you see the pannus has disappeared. And this we had discussed that this is not a primary problem. This is due to severe, severe buckling of the posterior longitudinal ligament. And this retroodontoid pannus is not a primary phenomena. Treatment of atlantoaxial joint instability is the issue. So in rheumatoid arthritis, you never do treatment for pannus, which is a secondary phenomena. You have to treat atlantoaxial instability, which is the treatment. So we described immediate postoperative regression of retroodontoid pannus after lateral mass reconstruction for rheumatoid disease. So we described that pannus is not a primary issue and pannus need not be treated primarily. So in skull-based surgery developed actually in the era of 1988, 85, 86, 87. Laligam Shaker was one of the big pioneers in developing of extreme lateral approach. And I was working with him at that time, during this time, when he developed this approach. And Dr. Sen was with him, who developed extreme lateral approach. And if during that time, whenever skull-based workshops were conducted 30 years ago, this is more than 32 years ago, extreme lateral approach was one of the most demonstrated approaches at that time. Petrosal approach, orbitozygomatic osteotomy, how to drill the petrous bone, how to build the temporal bone, how to expose and displace the vertebral artery was one of the very common form of treatment discussed in extreme lateral approach. And transcondylar approach, to drill the condyle, was one of the approaches that I also participated in demonstrating for several years during that time. So the main issue was to expose the vertebral artery, mobilize the vertebral artery, completely displace the vertebral artery, and have a lateral exposure and transcondylar exposure were done by me. For several years, I used to do those approaches. Even transoral approach was being recommended during those years for intradural lesions of the foramen magnum. So several years ago, in the year 1991, this is the letter by me, and which is one of the most highly cited letters to the editor. You will see in the PubMed, if you go, this is one of the very highly cited letters where I said that transoral approach for intradural lesion is not such a great approach. Alan Crockett had described and this approach with Dr. Chandranath Sen at that time. And I had said, no, transoral surgery is not such a great approach, but there were counter arguments and counter discussion, and this thing was quite heavily discussed 30 years ago, this letter to editor. So 30 years ago, I had also described this keyhole approach for lesions located in the region of foramen magnum. This is my approach, where I had described a supracondylar infrajugular bulb approach in this area. Between the jugular bulb and the condyle, this exposure, supracondylar infrajugular keyhole approach for some lesions located in the region of foramen magnum. So this is from my historical perspective. But then in the year 2008, of course, I had changed during that time, where I as I mentioned to you, I went more into conventional form of treatment, and more extreme lateral exposures were not done by me. And in the year 2001, 20 years ago, this article of mine, 2001, where I described that surgery for anterior foramen magnum meningiomas can be done by conventional suboccipital approach. So you must remember that I had done 17 cases, and this was my article during that time. And I completely switched on to midline suboccipital approach to foramen magnum tumors. And I will like to show you in this presentation, this approach. So this was and it is, and I have completely extreme lateral, far lateral, lateral, transcondylar approaches for anterior foramen magnum meningiomas I have completely abandoned for 20 years or more, or maybe 25 years. And this is my approach. So because in 2001, I had presented 17 cases, so maybe for 5-6 years, I must, from 1991 to 2000. So midline exposure, partial removal of suboccipital bone of foramen magnum exposure, partial laminectomy of C1, exposure of the vertebral artery. So this is one side, unilateral. I'm not removing the other side, arch of atlas, little bit across the midline. Exposure of the vertebral artery here over the arch of atlas, suboccipital craniotomy, removal of the foramen magnum, little bit going across the midline, and this is my exposure. Then elevation of the cerebellum, exposure of the lower cranial nerves, exposure of the C1 nerve root, cutting of the dentate ganglion, and exposure of this tumor. So this I'm going to show you that for 20 years or 25 years, for all foramen magnum meningiomas, which I have done several of these meningiomas I have done at that time. 17 was amongst the largest series at that time. Now, of course, my series is quite a massive series of foramen magnum meningiomas of various kinds. And all these meningiomas I have done by just exposure and quick exposure, control of vertebral artery over the arch of atlas here, if necessary, otherwise not even exposure, and control, and working within the tumor, learning the art of breaking the tumor. And many of these tumors I do in very quick time, and I will like to show you. So this is my exposure, suboccipital craniotomy here, exposure of the little bit arch of atlas removal. And sometimes if the tumor is going down, I may remove the C2 lamina. If sometimes this C2 spinous process can disturb my angulation to the foramen magnum, I may remove it. But this is the kind of exposure that I do, and my incision is midline, and then I retract the muscles across the midline. So first I will show you some tumors. Endodermal cyst is a very common, not very common, it is a rare tumor, but one of the tumors of the foramen magnum. And this was the largest series when I had published several years ago. In the year, I don't know which year this was, 2005, I had published these 7 cases. You must remember that 7 cases was large series at that time. Now my series is about 32, 33 cases of endodermal. So you can imagine these are relatively rare tumors. But what is important in these tumors is that you have to diagnose these tumors on the basis of radiology. You see on T1, on T2 weighted image, they are dark, and T1 weighted image, they are bright. So this is very special feature of endodermal cysts. Not There is no other tumor except for melanomas or hemorrhage where you can get such intensity. They have intensity like brain abscess, and they have consistency also like brain abscess. So these tumors do not need a very mega exposure. They are always located in front of the brainstem, and you will realize that to come in front of the brainstem, you may find difficulty and you may think that it is impossible and things like that. But you have a minimal exposure here, and this will drain off like pus. This is another tumor here, endodermal cyst. The most important character of this tumor is they are pre-medullary or pre-brainstem, and they have intensity like pus, and they have consistency like little bit of a solid pus, and you don't need too much exposure for these tumors. This is another tumor coming down on T1 weighted image. You see how white it is, and T2 weighted here it is white. So the intensity is not exactly like a tumor, but intensity can be quite variable. So this is on T2 weighted image. Here it is little white, and on T2 weighted and T1 weighted, it is little bit dark. And this kind of thing, you know, it looks like vertebral artery here, and this is basilar artery, but many of the times these mimic calcification. They are calcification within these cysts, and these cysts, this calcification, I call them soft calcification within the cyst. You see here, this is another tumor, T2 weighted, T1 weighted, looking like an arachnoid cyst, but this was an this is a endodermal cyst. This is another endodermal cyst going across the midline, and these are soft calcification. On T2 weighted image dark, on T1 weighted image bright. So you must remember that these cysts are like craniopharyngioma cysts, which are variable in their color intensity on T1 weighted and T2 weighted, variable in their color coding. You see, this is pre-op and this is post-op. These are one of the most easy, not most easy, one of the easier tumors to be removed. You have a little bit, not too much aggressive exposure. These are soft calcification. It looks like vertebral artery is right inside the tumor, but this is not vertebral artery. You don't have to remove the entire cyst wall in this tumor, but what you have to do is you have to remove the entire cyst content. You cannot leave the cyst content behind. So this is another tumor. You see on T2 weighted, it is little bit dark. On T1 weighted, it is quite bright. This is post-operative. So these are also foramen magnum tumors that you must know. This is on T2 weighted image. This is a little bit brighter here. This is soft calcification. This is varying consistency. And this is vertebral artery. And this is post-operative image. This is another endodermal cyst. This is another endodermal cyst. Sorry, yeah. Now I will, here unfortunately I could not show you any video because unfortunately I could not get it from my department. I am not going to the department these days, but I will show you one of these days. Meningiomas are the other more important tumors in this territory, and meningiomas can be having rugged edges right in front of the brainstem. And as I have mentioned to you, now my exposure is for these kind of anterior located brainstem, pre-brainstem. Lateral brainstem meningiomas are not too bad or too difficult, but meningiomas located anterior in front of the brainstem, what approach you will take, you can think about, but my approach is now conventional midline approach like the approach I have shown you. This is another pre-operative, this is pre-operative and post-operative image with very conventional kind of exposure, no elaborate mobilization of the vertebral artery, no condylar resection, midline exposure, and coming in this direction, half removal of atlas, having a control of the vertebral artery if necessary, and then debulking the tumor, learning the art of removing the tumor, breaking the tumor. These tumors are attached to the anterior aspect of the foramen magnum and clivus, and then you have to disconnect these tumors, and the coagulation has to be done at the end of the operation in the region of the clivus. This is another tumor you see. This is a very dangerous tumor. Everybody in the country had rejected this case. You see there is a calcification, ossification, not calcification, ossification within the tumor. The whole tumor is solid rock, and these arteries have got quite an intimate relationship in a solid tumor, and I had removed by a similar kind of exposure. Nothing to elaborate about this exposure that I had done. Now I have a follow-up of more than 16 years or 17 years with this patient after removal of this tumor, completely asymptomatic. This is preoperative and this is postoperative. Some calcification may have been left behind here. This is another tumor, meningioma. This is rather straightforward tumor. You don't have to do very elaborate exposure for such a tumor. This is another tumor, which I think I have the video for you, this particular case. This is encasing the vertebral artery. That video first I would like to show you here. Maybe this is another case. This is preoperative and postoperative foramen magnum meningioma. This is another tumor which is pre-op post-op meningioma with very, these are lateral located, posterior located. These are relatively quite simple meningiomas. So this is my exposure. Elevate the cerebellum, remove the, do some suboccipital craniotomy, open the foramen magnum, remove the arch of atlas. Sometimes, as I mentioned to you, I remove the C2 lamina if the tumor is going far down. Cutting of the dentate ligament early in the operation. C1 nerve roots can be sectioned if necessary, but of course you should not section C2 nerve roots unnecessarily. Nothing is without function. And you see, this is my exposure. This is the tumor preoperative and this is the postoperative. Now I will, this is, let me show you some cases first. This is preoperative. You see how the tumor is located anterior to the, both vertebral arteries are in very close proximity, and same is the exposure and same is the surgery. So let me show you two cases, okay? You be prepared for a different kind of surgery, not very elaborate exposure. You see here, this is the suboccipital craniotomy and this is the foramen magnum has been removed. Arch of atlas has been removed here. And then my, very quickly, no condylar resection has been done. And this is quite a complex foramen magnum meningioma that I'm going to show you. Many of these meningiomas may be quite breakable. And a large part of this operation is quite unedited version. So you have an opportunity to see quite a thick arachnoid, which I am first trying to, you see, what you have to see is how this exposure can give you wide enough exposure to the removal of the anteriorly placed foramen magnum meningioma. You see, this is the brainstem posteriorly displaced by the tumor. Vertebral artery is coming right in front here and then going through the tumor or behind the tumor. Then I am having the control of vertebral artery. This is the tumor in front. Now what you have to do is, once you have seen the lower cranial nerves away from the tumor, you have to aggressively remove the tumor. Rather than, coagulating this tumor heavily. If you go on coagulating, of course, then you may not be able to remove this tumor. So what I'm doing is I'm having vertebral artery, I'm pushing back, and now I am breaking the tumor in an aggressive fashion with quite a blunt kind of dissection. You see, many of these tumors are quite firm and rocky. Only thing is you have to have a, what you have to do is you have to work by breaking the tumor, demolishing the tumor. You have to learn the art of breaking the tumor. You see, I'm using knife here because of the firmness of this tumor. Of course, you will not like to use knife unless you are 100% sure where you are going and how you are going. Consistency of the tumor. This tumor looks too firm for micro scissor to cut this tumor for any kind of. So what I'm exactly doing is you just see how my direction of exposure and my direction of surgical attack. So there is nothing too aggressive about it. There is no need to expose extreme lateral and far lateral. I'm not doing. I'm breaking the tumor. I'm working within the tumor. I have mobilized not mobilized myself. The vertebral artery is quite behind the tumor in this case. But if it is not behind, then you have to identify and dissect. All cases may not be going as per your wishes. Many a times the tumor may be firm, tumor may be vascular, tumor may be quite intimately related to the brainstem, but you have to have a situation where your exposure is good enough to remove all kinds of tumor. And I have told you for last at least 25 years, I have not tumors any. I was doing earlier
Sorry about that.
exposure of the vertebral artery, mobilization of the vertebral artery, condylar resection. You see, I am talking of selected cases. Of course, if the tumor is quite aggressive, and then I may go into my historical exposures. But now, for majority of these cases, I don't need any kind of very elaborate exposure for foramen magnum meningiomas. So I'm going to just see how much my exposure is widened slowly and surely. And if you realize coagulation instrument does not come into my story at all, it will come probably at the end of the operation. Here I'm now coming with a micro scissor. You have to know exactly how the tumor is associated with the arteries, with the brainstem, with the cranial nerves. And if you know exactly, and many of these tumors are moving, and this is almost completely live without any editing, this tape. And many of the tapes which I'm going to show you today are almost unedited tapes. So you must remember that these tumors are difficult tumors, of course. But if you can demolish the tumor and you know exactly where the tumor is attached, where you need to have coagulation, where you don't need to have coagulation, where you need to cut, what you need to cut, you should not, of course, you can create a complication and that complication will be quite devastating. You cannot create a complication in these cases or in any case in neurosurgery. But on the other hand, you must also remember that our life is such where complications will happen and might happen, and we have to learn from those complications. And more important is you have to have a very, very good experience with these. And I have, there is no question, one of the largest, not one, the largest experience in foramen magnum meningioma. I will not give you any numbers because I don't have the numbers right now. But, in my hospital, which is an industry of tumors, an industry of cases, we do as more than 8 or 9 or 10 cases a day of such tumors, or sometimes even more than that number. My maximum number is 14 cases a day in one day. And most of the tumors and craniovertebral issues, and of course, I told you that I need longer period of time for three situations. One is glomus jugular tumors. One is arteriovenous malformation surgery, and one is bypass surgery. I need much more time than 1 hour operation. And all these tumors, this tumor which I am showing you is completely, you see, in 15 minutes, I will be removing this tumor. You will see a little bit of a blunt and sharp dissection combination, but what exactly is not time issue which I am trying to impress upon you. I am trying to impress upon you the exposure that I can get from a suboccipital minimum, suboccipital craniotomy handle above. You see the other side artery is stuck here. So I'm like, I don't know what is stuck here. I'm trying to preserve that thing that is stuck. It is going right up to the clivus. Of course, clivus is going across the clivus. On the other side, maybe you will be able to see the other side, vertebral artery and basal artery soon in this case. Lower cranial nerves, of course, have to be preserved. Vertebral artery, of course, has to be preserved. Pica may be troubling you. Of course, you have to preserve. There is no question. You have to preserve everything. You cannot say, I have removed this tumor and I have not preserved these vessels and I have not preserved this cranial nerve. This may happen sometime that you have not preserved, but the success of the surgery will be gauged by what you have preserved, and not by what you have removed. You see now you are seeing across the midline here. And I hope to show you more cases. Something is very badly stuck here. I don't know what is that. Maybe the lower cranial nerves are stuck here. These are the lower cranial nerves stuck. And you just cannot compromise the lower cranial nerves. So I think I have left some tumor behind on the lower cranial nerves. You will see the spinal accessory nerve, and you will see the dentate ligament. You have to section early in the, if the tumor is going down in the spine. Now what I'm trying to show you is, you see the clivus, and that is on the other side vertebral artery there. Possibly that is the basilar artery there, and that is the clivus. Some tumor I have left on the lower cranial nerve, and here is the condyle. Now you see here at the site of attachment of the tumor, I am coagulating for the first time in this operation, keeping everything under vision. Okay, what I'll do is, let us see whatever is going on. So here, maybe I'm trying to remove that small part also, and trying to identify the lower cranial nerves more clearly. As I mentioned to you, this is the part of the condyle and the clivus. This is the spinal accessory nerve root. So this is at the end of the operation where I'm just trying to little bit see around and see if something has been left behind or whatever has been not done and whatever is done. Okay, so what I'll do is now I will escape from this. But you see the brainstem here, I'm trying to move the brainstem, vertebral artery. This is the vertebral artery, basilar artery, cranial nerves. I think this is finished. So I'm going to the next. Now what I'll do is I'll go to the next case from the screen. John.
Yes, Dr. Well. What do you want to do?
John, am I with you?
Yes.
Yeah,
yes.
Yeah.
John, I
of
want to
course.
share the screen. Can you, I want to introduce another video here. Can I?
Well, you have to get off that screen share totally and start
How
the
should
video.
how should I do that?
Yeah, just get off the screen share totally.
No, I'm not able
and
to.
start and open the video itself. It's easy,
I'm
all right?
unfortunately not able to do that.
Yeah, you can get off the
No.
screen share. I'll get you off
John.
the screen. Wait, I'll get you off there. Hold on. Hold
Yeah.
on, I'll get you off. And then you can start anew.
Yes, yes. Okay,
start
okay.
anew. Okay, start anew. Let's start with a video. Okay, you fell off there. There you go. There you go.
Can you see the video?
Yes.
Yes, yes.
So this is another same exposure. You see the same exposure. Now another tumor I'm showing, I don't know what I'm showing you, but just enjoy whatever is there. Are you seeing the video quite clearly, I?
Yes, we are seeing it very clearly.
Okay, so this is the same kind of exposure. Now you see here.
Yes, it's clear, sir.
See,
Clear and
this is
nice.
the, John, after this finishes, I will like you to give me another screen share again. You see, this is quite a huge tumor in front of the brainstem. And these are the see, I'm introducing a knife inside. I will not recommend young people to do this. See, this is the vertebral artery behind the tumor. See, you see, foramen magnum meningiomas, you have to learn how to handle the tumor, how to break the tumor and how to attack the tumor. And your anatomical concepts in the region have to be absolutely perfect. You should know where will be the vertebral artery. You should know where will be the contralateral vertebral artery. But essentially what I have to show you is that even with little bit, even with smallish exposure, you can do a quite a dramatic resection of complex looking foramen magnum meningiomas. This tumor is also quite an unedited tape. I'm not sure. So you have to know the tumor. It is a firm tumor, rock-like tumor. Vertebral arteries here in very close proximity. Lower cranial nerves will be in closer proximity here. I am cutting the tumor just in front of the vertebral artery. Then I will have to see how I dissect the tumor of the artery. See, these tumors will come in our lifetime quite often. Then you will wonder how to remove this tumor. See, now the lower cranial nerves are in my picture. I will try to see how, you see here, lower cranial nerves. See, the tumor is quite firm. Tumor is not so vascular. If it is a soft tumor, of course, then I will use a different technique. Then it will not be that difficult. But majority of foramen magnum tumors, I have a feeling that majority of them are quite firm in nature. And when they are firm, they are quite benign in nature. And you remove them solidly, you immediately, the patient will improve in his symptoms. And if you see this, this is quite a big tumor, as you can imagine, but my exposure is good enough. And I don't need such a massive exposure. Now, this is the site of attachment of the tumor. And sometimes these tumors can be, aggressive suction can demolish the tumor, some of these tumors. You don't need to cut with a scissor and all those things. Here, the tumor looks very firm and aggressive. So, and that is why I'm using cutting and all those things. But otherwise, you don't need, many of these tumors can be beautifully removed. And I can say all the tumors can be removed, whether they are soft tumors, whether they are firm tumors, whether they are vascular tumors. You have to know when to coagulate, when not to coagulate. You see, this is in behind the vertebral artery, quite aggressive tumor, and quite aggressive my posturing for this tumor. And you see, I have pushed the vertebral artery behind. So essentially, you have to know these tumors. You have to learn to understand these tumors. And you have to learn to demolish these tumors. This tumor looks rather straightforward when you see them, but images are not so straightforward. Going now towards the site of attachment of the tumor and dissecting the site of the tumor from the clivus and the foramen magnum. You see, what I'm trying to do is, you see, this is the vertebral artery right in front of your picture. The tumor is behind the vertebral artery on the brainstem, and you have to see to it that you don't demolish any cranial nerve. If you demolish the cranial nerve, it will be a bad complication. You have to dissect the tumor, remove the tumor, identify the cranial nerves, form the tumor, and then you have to find your plane of dissection, remove the tumor, remove the tumor. These foramen magnum meningiomas can be beautiful tumors to remove. I must tell you that I enjoy removing these tumors like I enjoy the entire neurosurgery. You see, now I have got to the site of attachment of the tumor in the region of foramen magnum, and now the things are looking much better. Now this is the vertebral artery. Now I will probably mobilize the vertebral artery of the tumor capsule. You see the vertebral artery is now mobilized. Little bit editing was done there, it seems. The vertebral artery, the whole thing is under your control. And if you have a, suppose you have a tear, as then you have to hold it and suture it. You cannot leave the tear running or coagulating. You have to suture it then and there. Proximal and distal both. It's very rarely suturing will be required in foramen magnum meningiomas. But if it is required, you have to have the handle of it and suture it. You cannot leave it bleeding. You see, basically, if you realize that you have to just break into the tumor is not at all looking black. And if you have realized this surgical style, there was no coagulation coming in the picture at all. No bipolaring. See, this is the other thing that you will see now. I am dissecting the tumor of the lower cranial nerves, which are quite badly entrapped into the tumor. But there is no excuse. You have to save them means you have to save them. If you don't save them, you have a very nasty complication postoperatively. You can damage. I'm not saying you cannot damage. Sometimes the tumor has by itself damaged the lower cranial nerves. But your job is to save them. And your job is done perfectly only if you have saved the nerves. And here now for the first time any Surgicel is coming in the picture. No Surgicel, no bipolar, no monopolar. Monopolar instrument, I don't know this instrument. I don't know that instrument. What is that monopolar? I've heard about that. You see the whole of the now for the first time bipolar is coming in picture. And if you see the beautiful anatomy, I'm not able to show you where the lobe is here. See, these are the cranial nerves in front of the brainstem, and the beautiful anatomy in front of the brainstem. The lower cranial nerves will be in this area. Under no circumstance lower cranial nerves will be demolished.
Sir, are you doing in the prone position, sir?
Now you see.
Prone
Okay,
position.
now I will go.
Okay, you fell off the screen share there.
John, I will take the previous screen again, and you
Okay.
keep me.
Okay, just start anew.
Okay. Yeah.
There you go.
Oh, no, not this, John. Can you come back again? Okay, what? No, come back. I want to show some slides. Then I want to come here.
Okay, you want to take that off? Okay, let me take that off. Hold on.
I want to bring these slides. Yes.
Okay, start
Just
again.
a minute.
Okay.
Okay, so this was that foramen magnum meningioma that I had removed. And this was the other foramen magnum meningioma. I have another video, but maybe I don't show it. So the foramen magnum, if you would like, I will show you that case again. Aip, you think you would like to see another one?
He
Yes,
stepped away,
yes,
but-
of course. Yes, of course. I mean, if,
Okay, so
Sure.
this is a similar foramen magnum meningioma. No, I think this one. Okay, what I'll do is maybe after my presentation, I'll show you. Now I want to show you another tumor of the foramen magnum, which is C2 neurinoma. Okay, and as I showed you the other day, C2 neurinomas look like trigeminal neurinomas, and they have this kind of connection, and they may be located right in front of the brainstem, and they may be located right lateral to the brainstem or go in front of the brainstem. And this is the region where the C2 neurinoma arises from the ganglion, and then it goes inside the canal, outside the canal, and most important location is behind the C1, C2 articulation. So that is the point. If you know this, that these tumors are located behind the C1, C2 articulation in this region, and then they go in front and then go behind, and these are interdural in location. Like trigeminal neurinomas are interdural in location. Many of times, even this part of the tumor is interdural in location. Earlier in my story, I had said this is intradural, but now I'm saying it is, this part is also within the dural confines, and this, both of these combined is quite a large series, as you can imagine. Understanding that the dura is, this is the dura, this is also within the dural canal, okay? Interdural in location. Now, John,
Yes,
can you remove the screen share? I want to show you video
Okay.
outside
okay.
of this tumor, C2 neurinoma.
Okay, go ahead.
Okay. Now what I'm showing you is, I'm showing you the entire operation from skin to skin, okay? You just remember that I'm not showing you an edited version of this case. I'm showing you the entire operation from the skin. I'm not, you don't get impressed by the speed or things like that. What I'm trying to show you is that you have to know exactly, understand the philosophy of these tumors. So I am going from the skin incision. This is the suboccipital bone. This is this cross is the C2 spinous process, and my incision starts here now. And you will realize that in my surgery, the coagulation instrument comes very infrequently. Everybody has his own style, and I don't think that everybody should follow or will be able to follow this kind of unusual surgical style where there is no coagulation at all in the surgery. So here what I'm trying to do is completely, I'm trying to show you an unedited version of this operation. See, there is a large vessel which is bleeding. I will just retract it away for the time being and see what is to be done. So this is the suboccipital area. This is up. This is the C2 spinous process. And this operation also, I am not sure, if you were present, this was shown in one of my workshops. Now what I will do is, I will expose the C2 spinous process. Here is the C2 spinous process. This is the suboccipital bone. little bit. I'm just trying to maneuver this instrument there. This is the C2 spinous process. Here is the arch of Atlas. Subperiostelia, I'm trying to expose over the C2 lamina. You please a little bit ignore some of this, because this is not under microscope. This maybe it is under microscope. So you see, in few, I will be able to show you directly lateral mass. See here, I'm exactly on the tumor here. You see, this is the C2 spinous process, and I'm actually now trying to go on the tumor. You see, I'm cutting the dura over the tumor. This is the arch of Atlas. This is the C2 lamina. Understanding that this tumor is between the dura. Understanding that you don't have to expose the vertebral artery as long as you are within the dura. So I am working within the dura, little bit you have to get oriented yourself, working. And now here I am removing the tumor from the spinal canal. You see here, doing quite a blunt dissection by working within the dura. That is the trick of this operation, is identify the dura, cut the dura, then remain within the dura. There is not a single coagulation, even once the coagulation has not come in the picture up till now. I am not trying to impress upon you coagulation or no coagulation or quick operation, but I am trying to tell you that the philosophical understanding of these tumors are so critical. These tumor, which looks, many of these tumors, people will like to do extreme lateral exposure, exposure of the carotid artery, exposure of this, and I used to do it myself, let me tell you. I'm not telling you something that I was not doing myself. But after this, and also if you have realized such a large experience of these tumors can be done in quick time. And if you realize this is done in 8 minutes or 9 minutes, the entire tumor resection by understanding the fact that the tumor has been removed, knowing that it will not encase the vertebral artery, knowing that it will not be directly compromising the neural structures, knowing that it has a very well-defined dural boundary. You see this tape I have got, and you see the entire tumor has been removed, and you can gauge, you see, now this space has been, the tumor look like going inside the canal, but if you realize there is complete dura here. And I will again show you another case where the dura will be shown probably better. And now gel foam, will come and the stitches will be done. Now, John,
Yes,
again, I want to share the screen, please.
okay.
Okay, are you with me?
Yes,
So this tumor, how it was removed within very quick time. This is another tumor, and I must say this should not take more than 15 minutes to remove. This is a very straightforward. Cut the dura, work within the dura and remove this tumor. There is no need for proximal control or distal control. This is another tumor. You see, the whole thing is under the dura. Make a transverse incision in the dura and remove the tumor, and you can remove it very beautifully. So there is another case here. Let us see how this tumor was done. Now, this C2 spinous process is here, and you see the dura. Can you see, Aip, the dura?
Yes, we can see, we can see.
You see, I'm cutting the dura here. You see this dura?
Ah, yes, yes, yes.
And this tumor, C2 neurinoma, are outside the canal. There is no other neurinoma which is outside the spinal canal. This is the arch of Atlas. You see, working within the dura. Can you appreciate that? I'm not sure if you can appreciate, but I am working within the dura and extracting it like a. And also, you know what? C2 nerve root. These tumors arise from C2 ganglion. And the C2 ganglion can be preserved in these cases. I know I have repeatedly mentioned that C2 ganglion need not be preserved and all those things. That is all right. But I'm telling you, in some of these cases, this is the right side. This is the C2 spinous process. This is the suboccipital bone. This is a huge tumor. And I'm removing that tumor in a very, not like a microscopic surgery, but quite like a blunt surgery. The main thing is to learn the art of demolishing these tumors, learn the art of understanding these tumors, learn the fact that they will be confined tumors, and you can have a very nice, quick exposure, big exposure without the need for massive exposures and other things. See, this is the part going inside. Here, I'm having some issues to remove this. If I need, of course, I will open it more, but there is more often, there is no need to remove, to do any more exposure in C2 neurinomas. And as you know, these are very, very benign tumors. And as you know, these are tumors. You see the tumor. This tumor is also unedited version of this tumor resection. See, tumor surgery is a little difficult to show. If vascular surgery is a little bit more easier shown. To show tumor surgery videos is a little bit tricky because tumor dissection is quite an individualistic technical job. Everybody has his own technique of removal. Everybody has his own technique of dissection. Vascular, when you are suppose you are showing aneurysm surgery, the anatomy becomes much more beautiful to show. When you are showing tumor surgery, the anatomy is not so easy to show. Here, of course, the tumor is going right in front of the brainstem. And if you realize, I'm working right in front of the brainstem, but my job is See how quite a bit of tumor has already been removed. And my direction of my exposure is quite lateral. See, some tumor is still there in front of the brainstem, but I can turn the microscope a little bit more to get that part of the tumor. The main message for the younger people is to understand what tumor you are going to operate, to have quite an experience with these these are not easy issues. These can be quite difficult issues, and to show a complete tumor resection of this area is not such a, and without any editing of the tape, many of the things that you will see in most of the is just a few edited part of the video, but here it is not at all edited. This is the whole operation. You see now I have got enough space for me. I saw some tumor. These are some C2 nerve root, some fibers of the C2 nerve roots which are enmeshed in the tumor capsule. So I'm not sure. So that is the end of the story here. I'm not sure. I couldn't see that part. So this is the meningioma. Sorry for that. So I think I may like to show you this video, or maybe I just this similar kind of dissection. Let us go a little bit ahead here. So same exposure.
It's not playing, Dr. Gould.
Shakil bhai, I see you.
Whoop, he fell off.
Yes, sorry for that. Now it is back again.
Okay. There you go.
Yeah. So I'll go a little bit ahead here. So you can imagine the same kind of dissection, same kind of exposure, same kind of tumor, and same kind of aggression. And many of these tumors are quite beautiful tumors to remove. Only if you can. You must know that the vertebral artery issues can be there. Lower cranial nerve issues will be very prominent. See, the lower cranial nerve issues will be most important. You cannot remove the tumor and say, I have removed the cranial nerves. And you see this tumor, you can imagine that many of these tumors are completely unedited version of the tapes. More important is see the exposure. And my coagulation will come at the end of the operation, at the site of attachment of the tumor. You see the vertebral arteries there. You have to get the vertebral artery, you have to get the lower cranial nerves, you have to get the opposite vertebral artery, you have to get the basilar artery, and you have to get the tumor. And medially, more medially you go on the top, you will get the sixth nerve draped over the dome of the tumor. If bigger the tumor, you will, but you see here, there is no retractor, there is nothing, and there is vertebral artery right in front of me, and the tumor resection is being done. Many of these tumors will go low down in the spinal canal, where you have to remove, to mobilize the spinal cord, you have to cut the dentate ligament, and then you have to probably, if necessary, to mobilize the tumor, you may just cut the C1 nerve root, I'm not saying that I have cut the C1 nerve root. And if necessary, you may just cut the C2 nerve root. I'm not saying I will cut the C2 nerve root, but you might just. Yeah, I am working in front and behind the vertebral artery. See, the tumor is so firm that you cannot use micro scissor on this. You cannot break this tumor with a CUSA or with a suction. I am doing very firm kind of a aggressive tumor holding and cutting and breaking. See the vertebral artery? Completely in your view. There is no proximal exposure. As I have told you for last 20 years at least, I am not doing extreme lateral or far lateral or these kind of things. And for petroclival meningioma, I have completely abandoned petrosal approach, orbitozygomatic exposures for last at least 15 years. And during my own terrain with these tumors, I used to do quite aggressive exposures earlier in my lifetime. But you have to learn initially, I presume that you have to learn with bigger exposures. Fortunately for me, you know what has fortunately that my hospital is a public hospital. It is completely free for the people. And it is loaded with patients, and that is my property. And that is my huge wealth, which nobody in the world can compare. If you have not seen Mumbai, you must come and see. If you have not seen the slums of Mumbai, you must come and see my hospital. And if you have not seen this kind of surgery, you must come here. This is neurosurgery made simple. Neurosurgery made like very simple. Now I am coagulating the dura. And earlier in one of my presentations, I had told you that no neurosurgery should take more than 1 hour. 1 hour is the maximum neurosurgery that I take, whether it is acoustic tumor, maybe next time I show you some acoustic tumors, whether it is acoustic, whether it is petroclival tumor, whether it is cavernous sinus tumor, whether it is whatever tumor, except 3, glomus jugulare tumors, AVM surgery, and bypass surgery. So there are various kinds of foramen magnum tumors. And this is one tumor which is going like that. This is one tumor. You have to know how the vertebral artery is located. Sorry, this is a little bit of a repetition. So these are the This is, I have shown there is some kind of duplication here, but that is what I want to show you, IPE, and I hope you have enjoyed what I have shown you, and that is the world of foramen magnum tumors.
Absolutely,
And
absolutely.
I hope you have enjoyed the journey with me to these tumors. John, can you now connect me, get me out of this? Yeah.
Yeah.
Okay, so I'm sure many of you may be having many questions, and I'll be happy to answer those questions. Ipe, are you there?
Yes, sir. I'm here, sir. I'm here.
Ipe, can you initiate the questions now if anybody has?
Yeah. So first,
And if you have, I
first,
will be happy to answer your. If you have questions.
Frankly, I think myself.
I cannot hear your voice, Ipe.
Can you hear? Can you hear me, sir? Can you hear me?
Yes.
Yeah.
Yeah. So I always think, and many people who know me think that I am crazy when I do these cases, but I think I am much more sane than you. The way you're doing these tumors is something that, we'll have to get into that level where absolutely no coagulation, small exposures, and then have absolute knowledge of anatomy and then go take these tumors. And it's really, really, really impressive. Very impressive, I must say. We have to learn from you because I think most of the beginners won't even understand this because we've done these tumors and we know how difficult they are. And the way you are breaking them off and then you make them seem so simple, it's a hallmark of a master. It's beautiful, excellent. I mean, your experience, kudos to that. No, absolutely no, nothing to say. That is all I can say.
Okay.
Thank you, Ipe. Thank you.
Next question, next comment.
Professor Goel, how are you? This is Abhilash from Tampa.
Yes, Abhilash, how are you?
Very good, sir. Very good. Your surgeries are excellent. Can you please talk about closure? What is your philosophy with the dural closure in these cases? Because sometimes it takes a long time to close the dura.
I'm not getting your voice.
Can you discuss the how to close the dura in these cases,
Yes.
how to do it quickly, and your philosophy about that?
Yeah. Everything is difficult about these cases, Abhilash, as you know. But you have to learn how to make these things simple. And you have to learn how to make these things quicker. If you have lined up 10 cases a day or more than that, you cannot have even time to, you have to open the dura in a very proper fashion where you can close. And you have to make it like a flap. And you have to see to it that your opening, your opening is such that you can reconstruct properly. Your reconstruction cannot be half-hearted. You cannot do anything half-hearted in neurosurgery. You cannot say, I have done quick job and there is a CSF leakage in this operation. But you know what, my style of surgery, many of these cases, even I showed you the other day, craniovertebral fixation, the entire operation can be without a single bipolar, single. I will show you probably some acoustic where I have conducted in live surgery workshop. I showed 5 acoustics and 1 craniovertebral fixation in half a day. 5 acoustics. Can you? So that is become my style. What my style is, demolish it. Work within the tumor, work within the tumor, learn the art of breaking the tumor, learn the art of preserving the arachnoid, and then dissect around the arachnoid and preserve all the vessels around the tumor. You can imagine this large foramen magnum meningioma. If you coagulate 1 vessel on the dome of the tumor, you can probably kill the person. These vessels on the dome of the tumor may be coming from pica, may be coming from maybe important perforated to the brainstem. There is not a single vessel on the dome of the tumor which is which is a tumor vessel. All the tumor vessels are coming from the clivus and from the foramen, anterior wall of the tumor. So my style is to demolish the tumor quickly and go to the clivus as early as possible. And when you demolish the tumor, you have space for you. And then that space, that exposure, you use to coagulate the base. And once you have removed the tumor, coagulate the base is rather straightforward. And then you aggressively coagulate the site of attachment. That is my style of surgery. And that style I use for acoustic tumor. I say for acoustic tumor, you have to coagulate absolutely very, you coagulate inside the tumor, that is waste of time. You coagulate outside the tumor, that is a technical mistake. Now, how to do it? How to preserve the arachnoid? That is the trick of the trade. You can play with the tumor for hours and hours. These foramen magnum, I have shown you, all these were unedited tapes. All the tapes I have shown you are almost completely unedited tapes. And I have talked to you for this entire presentation, maybe 1.5 hours. You can see, you can realize how many tumors I have shown you. So this is the kind of, quickness also. You cannot stand on the tumor for hours. Acoustic tumor, I have seen people operating for 12 hours, 15 hours. My feeling is if you are doing that kind of surgery for acoustic, you probably need to learn more of acoustic tumor. If these tumors, you have seen how much exposure, you go in the neck, you expose the carotid artery, you extreme lateral, condylar resection, this resection, vertebral artery mobilization, you take 5 hours in exposure here. Many of these extreme lateral, I used to do, I have worked with people who have designed this exposure. I have grown up with these. I used to do myself, these kind of exposures. But over the period of time, as more and more life is going on, my experience is going on, my surgical time has reduced, of course, and my safety for my patients has improved, of course. There is no question about that. And the beauty of the whole thing my life has become simpler in this manner. Abhilash.
Thank you, sir. Thank you.
Yes, John.
So can I ask you a question, sir?
Yes, yes.
Sir, in case of a very good tumor, you have shown us this excellent job you have done and a very simpler way. But in case of vascular
Can
surgery,
you hold on for a second? I will use another instrument. Okay. Just a second. Just hold on.
Okay, sir.
Okay, now you go ahead.
Okay, sir. Excellent tumor surgery you have done, and we have seen a lot of.
Hello, I cannot hear, John.
Yeah. Hello, sir. Can you hear me? Hello. Hello.
Hello.
Can you hear me, sir?
Sorry for that. Okay, now I'm back.
Yes, yes. So you have shown us a very excellent jobs, and we have seen a lot of difficult, complex CV junction tumors. Basically, in case of tumor, we have got some space. The tumor creates some space so that we can go forward without creating too much of skull base work. a tumor has created some space for us. But in case of vascular surgery, just like complex vertebral junction aneurysm or vertebral artery aneurysm, is it possible to take the control of that particular complex vascular lesion without doing any skull-based work like what you have shown?
No, now I will tell you, this is specially for these kind of tumors.
Okay.
For meningiomas, the approach is different. For acoustic tumor, the strategy is different. For AVMs, for instance, AVM, your exposure has to be massive for AVM surgery. You cannot do with minimal exposure AVM surgery. You have to have the control of the entire area. Similarly, for vascular surgery, suppose you are doing some aneurysm and all, your exposure has to be quite big. And if you have to use skull-based exposures like petrosal approach and all those things for vertebral artery and all, maybe those approaches are more relevant in those situations. Your exposure has to be wider in those situations. More important is your control, how you do each situation, how you expose. You cannot work with minimum exposure, some complex cases and say, oh, my exposure was small. But of course, as you grow more, like ACOM artery aneurysm, you can do probably with a small exposure. MCA, you can do with a small exposure. But I like to do those aneurysm with a much wider exposure. Okay, Mohammed?
Yes, sir. Thank you, sir.
Okay, next comment, question. Let me see here. Let me just go through some of the questions on the bulletin board. Hold on. Okay.
Sir,
Okay. Go ahead.
So this tumor you have done in the prone position without any lateral?
Yeah, this another thing you can do in prone position, you can do in park bench position, or you can do in sitting position. This operation which I have shown is sitting position.
Okay.
Okay, Faith Yavez asked, do we need flow measurements for all bypass operations?
No, that is a question to the previous speaker, John.
Oh, sorry about that. I'm sorry about that. Caught me. Okay. Comments, questions? Don't be afraid. It's a big opportunity. I know if I was a student, I'd be using it, or a resident.
Sir, for C2 Meningoma, if the vertebral artery is encased, what is the tips of you to do that? Hello, sir. Can you hear me, sir?
Did you hear that, Dr. Well? It may be frozen the screen. Let's wait a second. It usually unfreezes pretty quick. We got through most of the presentation without a problem. Usually there's one at the beginning, but didn't happen today. Well, I'm going to take this opportunity to have a commercial. Okay, we have these presentations in a couple of hours from Africa. 3 presentations, one from a resident.
Yeah, John?
Yes, you're back? Okay. Well,
yeah.
Okay, I'll do that commercial later. Okay, go ahead.
Sir, if the vertebral artery is encased in case of C2 Meningoma, what is your tips to do that?
That is what I said, Mohammed. that vertebral artery will never be encased in C2 neurinoma. There is a clear-cut dural boundary over that. And these C2 neurinomas are always within the dural confines. That is the message that I have to give you, that C2 neurinomas can never go, never encase the vertebral artery. Meningiomas can encase, and then you have to dissect, and you have to preserve. And if you injure, you have to take care, and you have to handle it somehow or the other.
Thank you. What are the situation when you have to take the laminectomy of the C2 or C1 in case of C2 neurinoma?
C1 laminectomy, extremely rare. In C2 neurinoma, extremely rare. Laminectomy, C1 arch may not be necessary to remove at all. Never, almost never. Okay, Mohammed? Okay, John, is that okay?
Yes.
Okay, so should we wrap it up?
Okay, I think we're about ready to wrap it up. Thank you very much, Dr. Goel. And
Thank
tomorrow, any idea of the topic tomorrow? Oh, wait a minute. Aminata has a question. Aminata, I don't believe it. Oh, we just said thank you. Okay.
I was just saying thank you.
Okay. That's nice. That's very nice to do. Okay. Okay. Any idea on the topic tomorrow, Doc?
I will give you the topic very soon. Okay.
Okay. Very good. Okay. We'll see you tomorrow and see everyone else tomorrow. Thanks for coming out.
Bye-bye.
Bye-bye. We'll stop that. Okay, that's stopped officially. And now, Dr. Goel, I'm going to do a commercial. I'm going to see if I can screen share. Okay, the presentations we have in a couple of hours from Africa Grand Rounds. Residents presenting this presentation. And Victor Hugo Perez, he's a very well-known anatomist. He's excellent. Latex injections, you can really see the vessels, arteries, and veins of the spinal cord. He's going to be talking about traumatic brain injury. And then a Sudan neurosurgeon is going to be talking about temporal bone anatomy. And we move this over to another time. So you're all welcome to come to that. The link is at the bottom. I'll put that link in the bottom. Yeah, that's a good idea for me to do that. See, I'm learning the business side of this. Let me get the link. To come into the panel of any of the African ones. Okay, I'm putting the link in Africa Grand Rounds. That come through? You see the link? Did it come through?
No, sir.
Okay, hold on. Still not coming through? Oh yeah, the link came through. African Neurosurgery Grand Rounds. Okay, and there's another presentation after that from a London neurosurgeon. Let me screen share that. Okay, that's at 9 o'clock London time. Chiari malformation. He likes to speak about Chiari. I think he's pretty well known. Anyways, he's speaking about this, and I'm going to put that link in the chat bar too. Okay. (9 p.m. London time), and that the link is there to come into that panel. So I'm learning because we got 30 people that can hear me now. What do you think of that, Amir? Are you there, Amir or Ibrahim? Geez, no one's complimenting me on my business acumen. We're advertising acumen.
John, you're doing very well.
Hey, how you doing? Hey, Abraham, yeah, you've been quiet today.
Yeah.
I'm here.
There's Abraham. There's another Abraham.
Yeah.
Well, you know, because it's a good thing to announce to people because they're interested in other conferences. So this is the best time to.
You know what happened, John?
What's that?
When you started, when Professor Ibe started these daily classes, there were hardly no other webinars on neurosurgery, and now there are multiple every day.
Oh yeah. Well, you know, I'm trying to somehow organize them because
Yeah.
I'm trying to tell the organizers that, hey, you're not competition. I'll put your Zoom on the website. So it's
Yeah.
a central place to find, you know what I mean?
And to collect all the
If anybody has a Zoom cast, I mean, just to let me know and I'll arrange it so that it's televised also. In other words, you can televise it the way you normally do, but I'll add another element to you and may bring some viewers from Neurosurgical TV. You know the concept, Khalif, right? It's like in television, it's the same thing. You just put it on another station. It's syndicating. It's called syndicating in television. It actually just adds more viewers to what you're showing. It doesn't, which it's okay for me because then I don't get involved in production of having to film it and make sure the audio is okay. They do that already and basically just give me a link. You have a lot of free time, Abraham?
Well, I might stop by for the for Dr. Perez for Victor's presentation.
Oh, you might what?
I might stop by for that one.
Oh, good. Yeah. Victor's always good. I mean, he gets rolling and he doesn't want to stop. But it's good. So, okay, I better get going, get ready and go eat.
Do that, Dr.
Well, you know, the hours are so crazy, Abraham. You know, I don't know what to eat. What, you know, am I supposed to eat now, or is it dinner time, or breakfast, or what is it?
Right.
Okay, we'll see you later.
I'll see you later, Dr.
Bye,
John.
everybody. I hope you
Thank
come
you.
to the African ones. Great. Thank you. Okay, let me shut this.